Good afternoon, good afternoon, good afternoon, everyone. Good afternoon, good afternoon, good afternoon, and welcome back to day 2 of the Ccfpj-Jvma chapter and JVMA, Jamaica Veterinary Medical Association's One Health Conference 2024. Together we are stronger. This is day 2, January 14, 2024. And before we even go into the prayers and the introductions, I would like to apologize about certificates yesterday. You guys got a couple of emails. There was a little bit of mishap. You know, when you sign in a piece of paper in early January, you still put in 2023 instead of 2024, even though there was a year change. That happens to us in tech as well. And so I want to apologize for that. But hopefully you've received your corrected certificate. If you haven't, don't worry. We're going to ensure that the system sends you your certificate for day 1 and day 2 a second time during the week. All right. So expect that you'll even see your day 1 certificate resent to you during this week, maybe about Wednesday. And you'll be sure to have your full CMEs for participation. Okay. But with that said, thank you guys again for joining. Thank you for coming yesterday. And we look forward to continuing our education today with another wonderful day of presenters and events. But first, we're going to have the One Health prayer. Please allow me to play the One Health prayer lyric video so that we can begin the day. Thank you so much.
Let us pray. O God, our Heavenly Father, nothing can be achieved without us acknowledging your presence. And every day that a patient and an animal is cured through our hands, it is because of your will. Enter into our hearts today, we pray, and help us to continue our respective medical practices in good faith and honesty. Lead us, Heavenly Father, through life's tempestuous seas, and teach us, dear God, to remember that whatever we do, we are serving you. Have mercy on each and every one of us, as we ask you to hear this our prayer. Amen.
Amen, amen, amen. So, a little bit of housekeeping before I hand over to Dr. Paul Cadogan. Of course, Dr. Paul Cadogan is the co-chair of the One Health Conference Planning Committee. Before I hand over, it's about the requesting of CMEs, which I'm seeing now by Dr. Brown, and I've been seeing it all of yesterday. You do not have to request CMEs. Requested CMEs means that the committee has requested the CMEs from the council on your behalf. So you don't have to sign in, you don't have to put an email address or your name, etc. into the chat, right? So if you can hear my voice, if you can hear what I'm saying, you do not have to request CMEs. Your CMEs are based on your attendance and participation, and that is what we're looking forward to today again, your attendance and participation. So I hand over now to Dr. Cadogan. Have a wonderful day, guys.
Yes, good afternoon, everybody. Welcome to day 2 of our Ccfpj-Jvma One Health Conference. Just a few opening remarks to start the day. I mean, yesterday we had a wonderful day, and I have to say, in our opening remarks, Dr. Paula Henry outlined the planetary health concept and the core issues at the heart of it that are so vital to the future of life on planet Earth. We're all grateful for her setting the stage for the presentations that came after, that had so many in our audience saying, wow, eyes were opened yesterday. And we hope to do the same today too. I mean, the partnership between the JVMA and CCFPJ bringing you this One Health Conference is but a tiny part of what must be done to build a healthy and resilient future. Our objectives are to educate, energize, and motivate our audience to take the message beyond the conference to their workplaces, their communities, their homes, to their own lives. The process of organizing this conference is certainly a collaborative effort. Our committee meets, brainstorms, looks at current One Health issues in the world, develops a list of possible topics, possible presenters, possible sponsors, and then we're off. Like horses, approaching, discussing, recruiting until all comes together. Sorry. Sometimes it doesn't all come together as initially expected, but that's okay, because come together it does, and the result is what you have been experiencing over the past couple of days. Relevant, practical topics at the end of the conference make us more knowledgeable and better equipped to carry on in our diverse professional capacities, appreciating each other and working together better. So we need to push for official adoption and institutionalization of the practice of One Health by the powers that be, with proper mechanisms for governance and collaboration. The international templates are there. There's a strategic plan that came out of the One Health, One Caribbean, One Love project in our region, for starters. And at the global level, there's the WHO, WOAH, FAO, and UNEP quadripartite, just to mention two. It needs to be done. And we call on the powers that be to act. That being said, One Health is not just for government and professionals to work on. It is about every person, you, me, everyone, getting involved and playing their role to ensure that the survival of not just us humans as a species, but of all the other species that populate this incredible globe that we call home is supported. Let's spread the word and bring others onto the bandwagon. So we call on all of you in attendance to carry this forward and act, right? We are trying to do our part here. So I won't detain you any further. Let's get going on today's knowledge feast with our cadre of professionals of excellence, infectious diseases, EDI, human-animal bond, and mental wellness. So enjoy. One world, one health, one family. Thank you.
Thank you very much. I think we're now going to hand over to our moderator for the session, but not seeing where she's logged on, Dr. Cadogan. Dr. Leon, are you with us?
I'm not seeing her in the group here.
No, I'm not seeing her either.
I'm not sure what's happening. I got a message from her short a little while ago. So, which means, that means I'm going to have to fill in like I did yesterday. Okay. Let me, okay, so let us get into our first presentation. And this one, we would like to welcome Dr. Kisson, Dr. Niranjan, better known as Tex Kisson, professor. He's a native of Trinidad and Tobago. Hold on, I lost my screen here. Okay. And is currently based at the University of British Columbia in Canada. He's president of the Global Sepsis Alliance, co-chair Pediatric Surviving Sepsis Campaign, vice president of the Canadian Sepsis Foundation, advisory board member of Sepsis Alliance USA and the African Sepsis Alliance. So this gentleman he lives sepsis. We have one of the top people in the world talking to us today. He's chair of World Sepsis Day, International Pediatric Sepsis Initiative, Pediatric Surviving Sepsis Campaign Guidelines Committee, and he's the holder of the UBC and BC Children's Hospital Professor in Critical Care, Global Child Health Department of Pediatrics and Emergency Medicine at University of British Columbia in Vancouver, Canada. He's a recipient of the 2020 Doctors, I don't know if I can say this name, Vidyasagar and Nagamani Dharmapuri Award for his sustained exemplary and pioneering achievements in the care of critically ill and injured infants and children, and the Society of Critical Care Master in Critical Care, their highest award, and the American Academy of Pediatric Distinguished Career Award. We have a decorated health professional among us today. So we welcome Professor Tex Kisson. Prof, over to you.
Okay, thank you very much for that warm introduction. Let me try and get this slideshow going. Okay, yeah, thank you very much. I know it's very difficult introducing someone when you are a pinch hitter. So Dr. Cadogan, I sort of see you in a very unenviable position. Now, I am a pediatrician, but I must confess to you guys, this is the first veterinary conference or speaking to veterinarians, although I've worked with vets across the world to help design guidelines for small animals in sepsis. And at the same time, I must say veterinary medicine was one of my first loves. But I've been told time and time again, pediatric is very similar. You're taking care of the entire family, not only the child. The children, the younger ones are usually not cooperative, and occasionally they may try to bite you. So I feel at home here. And I'd like to congratulate the organizers of the conference. I think it shows great foresight in the presence of the world we are in right now. I have always been and still is a Caribbean man at heart. And I'd like to talk to you about a global burden of sepsis, because sepsis plays into exactly, it's central to health across the world. And many people may ask, what is sepsis? And in its simplest form, any infection that leads to organ dysfunction in the body and disability or death is sepsis, disability and death. So you can get it from pneumonia, diarrheal diseases, malaria, Ebola, and yes, COVID is sepsis, severe COVID, bacteria, viruses, etc., mixed infections, and hospital-acquired infections, especially in poorer countries. And I am pleased to talk to you guys about sepsis today, because I hope to convince you at the end of this that sepsis is indeed a global problem, a major problem in the Caribbean, and what we need to do is push to get a Caribbean Sepsis Alliance. So the things I'd like to spend some time talking about: the overall burden, a little of the burden in the Caribbean, the many faces of sepsis, and you will see what I mean by that, the needs of the Caribbean, and some final reflections. Now, we did a study and published it in Lancet in 2020, and there was little known about the burden of sepsis. So we worked with the IHME, that's the Institute of Health Metrics and Evaluation at the University of Washington. And what we found, we were surprised that based on our study, and there were some estimations because of data was scant in some areas, there were almost 49 million cases of sepsis worldwide, 11 million sepsis-related deaths, and 1 in 5 individuals in the world who died, 20% of all global deaths, sepsis was implicated. Now, these are startling figures, and in fact, it was twice what is thought. But the other issue, and many of you have heard, having gone through the COVID issues recently, long COVID. And long COVID is sepsis. And the fact is that with sepsis, bacterial sepsis, viral, whatever, when you treat someone, that's not the end of it. 1/3 die within a year. 1/6 experience significant morbidity and functional limitations, and 40% are rehospitalized within 90 days. So it is a major burden. Now, I put a slide here and speak about a false dichotomy. And this is because, having spoken to policymakers in the Caribbean for decades about the issue of sepsis being a major problem, and I was told that sepsis is not a major problem, it's non-communicable diseases. But in this study, nearly half of all sepsis-related deaths in 2017 were complications of injury and non-communicable diseases. So many of the patients who died worldwide had hypertension, obesity, diabetes, etc. So the point I'm trying to make here, in the Caribbean, it's not one or the other, it is both that we need to address. The other thing is that children, sepsis is heavily weighted towards children under 5, with globally about 40% of cases, or 20 million children incident sepsis cases, and almost 3 million deaths, 26% of related sepsis cases. So it's a big issue, especially in the early neonatal and under 5 period, and in the other extremes of life. And I point out that because in the Caribbean, we have to decide also what are the target groups for major investments. And when we look at the Caribbean, on the left, one can see male and female individuals in the Caribbean, this population pyramid starting at 0 age to 100 years. And one can see that there is a large population, the younger age group in the Caribbean, unless as we get older there. If you compare this to Africa, where I've spent many decades working in sub-Saharan Africa, one can see many of the countries there, the under 5 population, or over 50% of the population is under 16 years of age, and hence the models have to be different, and hence that's the reason why, as a pediatrician, I concentrate much of my effort in these areas of the world. If we look at Trinidad and Jamaica, in these Trinidad on the left, it's a very interesting distribution for both. But again, you have a large younger population, smaller numbers above. Yes, so I think that as policymakers, we also have to think in terms of where we are going to invest and how much we are going to invest in various areas. There is no doubt that sepsis is a disease of the poor and disadvantaged, and low and middle income countries bear the highest burden. There's an inverse relationship between income level and incidence and mortality. In fact, 85% of the sepsis cases and 85% of deaths occur in the low and middle income countries, especially in sub-Saharan Africa and Southeast Asia. They have the highest burden, as one can see from the graph. The other thing is that why concentrate on sepsis? Not only because of the enormous burden, as Dr. Tedros at the WHO said, sepsis care is the bellwether for quality of care in health systems. So if we get the care for sepsis correctly, from infection prevention and control across the board, we are going to improve health systems across the board. And when we look at burden of sepsis in the Caribbean, on the left of these regions, one can see 8 standardized incidents as we go up. It is very high in sub-Saharan Africa and Southeast Asia, but here is where we are in the Caribbean region, the green areas there, that's the incidence, and this is the 8 standardized mortality in the Caribbean region. So there is a lot that needs to be done in the Caribbean. What we would like to do, and I think everyone would agree, is while we have varying income areas, we would like to be up in this area, in the high income areas in Central Europe, etc. One of the major problems in the world, in fact, one of the biggest issues of the WHO is the issue of antimicrobial resistance. And again, when we look, the antimicrobial resistance is high in the Caribbean. And in this study we did, which was published in 2022 in the Lancet, the antimicrobial resistance or death attributed to resistance is increasing in the Caribbean. And it is something that we need to be very cognizant of. And I think that we globally, I'm glad this conference brings everyone together. because 80% of the antimicrobial agents worldwide are used in animal husbandry, 50% in China in the usually in the pig industry. And unless we think of the planetary health, we are not going to make much of a dent in this area. Now, when I speak about the many faces of sepsis, sepsis is a medical problem. We know that there are varying etiologies, as I showed you, in different parts of the world. These etiologies will vary. In poor countries, there is delayed recognition, lack of recognition and treatment. And across the world, there are many people who are dying from sepsis, preventable sepsis, when they should not. It is also a socioeconomic problem where those who are educated, who has money, seek healthcare, better healthcare seeking behavior, and they are less likely to get sepsis, as I've shown. And empowerment of women is very important. In fact, if one looks at the data globally, Bangladesh were able to achieve during the Millennium Developmental Goals, all the goals, and one of the prime reasons was the empowerment of women. And having worked in many districts in Bangladesh, I saw that better health seeking behavior for their children by women who were empowered and who were having jobs, etc. It is also a political problem. And we saw that very quickly during COVID with the issue of government priorities in different countries changing, the issue of staff shortages and poaching of staff, especially in the rich countries from the poor countries. Drug shortages, again, is a problem across the world. And we saw the vaccination issues and the inequity that was created during the COVID period for vaccines. In fact, Paul Farmer, who recently died from Harvard, has said, many political borders are like semi-permeable membranes, often quite open to diseases, usually infectious diseases, and yet close to the free movement of cures. Thus, the inequities of access can be created or buttressed at borders, even when pathogens cannot be contained. And I think in the Caribbean, we know that very well, and there's no doubt that an alliance would help in that creating a community of practice to help with infectious disease is very important. In fact, my colleague and good friend, Moshe Nagavi, who is at the IHME, has said that poverty is the mother of inequality in health. The unequal distribution of resources that are expanded due to climate change and increase in violence. And low and middle income countries obviously is higher. Life expectancy is less by 34 years. Under 5 mortality is 100 times higher. Death due to violence is higher. And antimicrobial resistance are 12 times higher. And we need to address that. Now, this is the Sustainable Developmental Goals, which many of you may know. The goals that we will be judged by worldwide by 2030. And while good health and well-being is central to our healthy lives and etc., one can see many of these goals that are being discussed in this meeting in the One Health or planetary concept is very important to healthy lives, but infectious disease. The issue of poverty, I mentioned already. Number 1, no poverty. Ending hunger. In fact, 50% of children who die across the world, their death is complicated by malnutrition. Quality education, I will show you a slide on education. Gender equality, the clean water. You can go to every one of these and look at the issue of responsible consumption of antibiotics, etc., health of the ocean, and peace in the world. They all, I would say, plays into sepsis, and I will show you some of this clearly very quickly. Now, this is a very interesting study was just published a year ago, a little over a year ago in the Lancet. It showed that when mothers have completed high school education, their children has a 31% chance, less chance, under 5, of dying. And when fathers completed education, it was 17% less chance of their children dying. This was a graph from UNICEF that shows on this axis, the longer that young women were kept in school across the world, different countries, mortality decreased dramatically, under 5 mortality. And this was a poster that I saw in Pakistan in a school that really showed send girls to school, the importance of young ladies being in school for long periods of time. In fact, a few years ago, I was at a conference in somewhere in Europe, and I was, at the end of my talk, I was asked by the moderator, he said, this is an unfair question, but if I give you all the money of Bill Gates, what would you do? And I said, that's the simplest question I've got. Keep young ladies in school and empower them. Now, the other issues that lead to sepsis, overcrowding. This is a favela in Brazil. And while we are able to live in crowded conditions, it's a triumph of modern medicine and vaccination. It is also our Achilles heel in that urbanization and crowding are going to lead to megacities. You see in our area of the world, Mexico City, Sao Paulo, etc., over 30 million, and this is going to cause spread of pandemics and those things. In 2015, I said the greatest migration wave since World War I. This was in Munich, Germany, and my colleagues were seeing diseases from Africa, African spiral reaction fever that they have never seen. Well, 3 years later, I was wrong. This is the Rohingya refugees in Bangladesh. And again, I was invited to several meetings talking about the problem of unclean deliveries and sepsis and death in the undernourished population in this area of the world. The Ukraine war, as we all know, is still ongoing. Now it's a larger 12 million people, as said, have fled their homes and displaced. And what it is, as you can see here, people are dying from sepsis, from shrapnel, the premature babies, infections, lack of medical help, bad nutrition, creating a high preterm death rate. A lot of it has to do with poverty and infections. And this is Ukraine. Now, what are we seeing in Gaza is the same thing. Newborns are dying. And if you read this, I said, people are suffering. They could die slowly with sepsis, infection, and gangrene, or some are going to die when the respirator stops. Again, infections and sepsis is the scourge of the world in so many different ways. Climate change is the Lancet Commission on Climate has said that when we think about health, the health experts have said, when we think about the environment, climate change can matter as much or even sometimes more than our personal behavior. And if the present trend continues, we can reverse the last 50 years gains in medicine. And you can see the number of articles in PubMed, over 7,000 in the last few years of climate change and disease. Again, underline the importance of this conference. So those are the many faces of sepsis. Now, I think I'll be, it would be arrogant to think I know the needs of the Caribbean, but I think a sepsis alliance where we can get together and discuss all the needs would be very helpful. And I think that this is where I'm going. Someone yesterday spoke about advocacy, and I cannot overemphasize advocacy. In fact, this is a statement that was made by a pediatric oncologist, Sidney Farber, who worked at Boston Children's years ago, and he saw many kids die from leukemia. Those are the days of very little treatment. And he came out and said the campaign for a disease is much like a political campaign. It needs icons, mascots, images, slogans, etc. For an illness to rise to political prominence, it needs marketing. It needs to be transformed politically before you can transform it scientifically. And this is what I think we need also in the Caribbean for sepsis. Laurie Garrett wrote 2 very informative books, and she predicted the Ebola crisis about a decade before it happened. And what she said was, for pandemics, which is what is going to happen more and more now, we are now seeing the influenza across the world again, which is sepsis. We need pharmaceutical laboratory government. We need everyone worldwide fruits of science with politics, sociology, economics, and even the elements of religion, philosophy, and psychology. And I can tell you in many of the poorer areas in the world that I work, we even go to the shaman because in many cases, they are the most powerful figures who would help with our program. So in 2010, we started as Global Sepsis Alliance, started in Long Island, New York, and you can see the founding organizations here. I was at that time president of the World Federation of Pediatric Intensive Care, but we got a lot of press, which was very important. And we then formulated World Sepsis Day. And I'm proud to say this has grown every year across the world. And one can see the amount of celebrations across the world that we have now increasing every year. We then were very much interested in getting a resolution at the World Health Assembly. And what we did at that time, we had to get low and middle and high income countries to support us. And I lobbied at that time, and Jamaica was very instrumental in supporting us. I invited them to the meeting in Geneva, and they helped very greatly, as well as members of PAHO. And what we did is this commitment, the sepsis resolution at the World Health Assembly. We had signatories of over 190 states. There were no dissenting votes. And it's really, these are the type of things, and this is what an alliance in the Caribbean would need to do: prevention, diagnosis, and treatment in national health systems, implement standard and optimal care, increase public awareness. In fact, we have done surveys across the world, and public awareness is very low. It started at 19% a few years in the US. It is now 66%. Train health professions on infection prevention and control, and promote research and innovation, because research and innovation from high countries may not be relevant in low middle income countries. And in fact, some of the work I'm doing in Sub-Saharan Africa, Asia, we are using frugal technology in very innovative ways that have enhanced care in sepsis. We have started many regional alliances, the African Alliance, and I can tell you, even in, I was in Sudan a couple of years ago, we had the Khartoum resolution, and even with all the violence and the problems, political violence in Sudan, our colleagues are still participating in the meeting and continuing the fight. African Sepsis Alliance is working very closely with the African Union. We did an Asia Pacific with Australia and the islands and the countries down there. Eastern Mediterranean, Europe, Latin America, North America is getting going. And we need this alliance in the region here. Because whereas we talk about global sepsis, sepsis as itself is a regional problem. And unless you can get alliances there that leads to national action plans, we are not going to get anywhere. And there is good news. On the 10th of January, just a few days ago, Pan American Health Organization had this meeting to develop a strategy and action plan to decrease the burden of sepsis in the Americas through an integrated approach. And that was a very, very well-attended meeting. And I am very, I would say, optimistic about this, because I worked for many years trying to sort of help get this going. And I think that a Caribbean alliance would be very useful at this time. The time is right. Some final reflections. I think we recognize sepsis as a global health priority in this World Health Resolution. We published in New England Journal of Medicine what needed to be done with another publication I did in the Pediatric Journal. But again, as Sir Liam said, the public and political space in which sepsis needs, it has to be in that space for the order of things to change. And I know some of my colleagues who are on this have been down in Trinidad just recently, and we are trying to get this alliance going. And the global strategy, really, this is for infection prevention and control, which is really for sepsis, is to prevent infection in healthcare, act to ensure that in IPC programs in place and coordinate IPC programs with other programs, health emergency, WASH, et cetera, et cetera. And I must say, I'm very pleased also that after the years working with the Global Sepsis Alliance as president, we have now engaged the G7 and G20. They are also now using the word sepsis, which they have not used for years, and we are getting it in their meetings, as well as we just earlier this year had a side meeting at the United Nations Assembly in Washington, D.C. We also had a Berlin Declaration about a month ago, and we continue to go back to the World Health Assembly to rejuvenate this issue of sepsis. And as a global health emergency, these are the things we need: public awareness, education, support, training, policy, and advocacy. The CDC in the United States have put an edict for hospital care that gives most of these things that you see on the right here. One might ask, why do we do this? Why don't we just take care of our own little island or region, etc.? And I bring this two statement forward from the presidents of the American Society of Tropical Medicine and Hygiene. In 1944, during the war, William Sawyer said, "No country can live to itself in disease prevention. A failure of one is a failure of all." And I think that is very true and underlines the importance of what you're doing. Richard Garrett in 1997 was talking about children's problems worldwide, which is close to me, said, the solutions to these problems are the solutions of our problems. One thing I'm sure of, how they and the disadvantage across the world fare is what will clearly determine the destiny of us all. And I think that that's very important. And my heart and soul is in the Caribbean, and I will certainly continue to support this. Well, for those who don't have the moral bend, there are consequences. These are the diseases that are endemic or pandemics across the world. And when one looks at the daily flights, 100,000 flights per day, and this is even more now with at least 1 million individuals, at least 8 million individuals, or 1% of the world population in the air at all times, one can see how quickly diseases can spread. So we are not immune. Finally, I want to bring it back again to what I was saying about poverty. Thomas Friedman had this book where he said the world is flat. And he was talking about having gone to Japan and been a factory with only 3 individuals to build cars, mechanized. He said, technology is making the world better and flat. And then he went to the Middle East and there were groups fighting over a 1,000-year-old olive tree. I think the world, it is not flat, it is more spiky now because of technology. When we talk about technology in North America or in the developed world, we talk about innovative technology. My colleagues in Africa talk about liberation technology. It liberates them from poverty. So I tell colleagues when they said for the COVID, we were all in the same boat. I said, no, we are not all in the same boat. We are all in the same storm, but we were in different boats. I'm sure you can appreciate that. This is a colleague of mine in Africa sent this to me. She has known me for years and worked in sepsis with me. She said, almost everything is possible if you put your mind to it. I'm an eternal optimist, and I invite everyone to join us in this fight. Join the Global Sepsis Alliance. You can just go online and join it. It's free to fight, share our vision, fight sepsis. This African proverb have driven me. Say, if you want to go fast, go alone. If you want to go far, go together. And I hope we will choose together. And I hope I've convinced you that sepsis is a problem that warrants the attention of the Caribbean, and an alliance would help greatly. Thank you very much, and I appreciate you inviting me here. I'll stop sharing.
Thank you so much, Professor Kisson. Thank you for your presentation.
Thank you.
So I want to open up the floor. Good afternoon, everyone. I want to open up the floor to any questions. We're going to have a very short period of questions and answers. If there's anyone that has a burning question and you haven't typed it in the Q&A yet, Let me check the chat. I don't think I saw any questions in the chat either. I do see lots and lots of excellent presentation, interesting presentation, excellent, lots of excellent, awesome. So lots of praise for your presentation, Professor. Thank you so much. And one person says, we'll definitely benefit from a Caribbean alliance. Thank you for sharing. And very informative, very interesting. Lots of kudos and praise for you. And as you can see, the emojis are rising up, hand claps and thumbs ups and hearts, all kinds of love for you. Dr. Cadogan has a question. Please go ahead, sir.
Yeah, I just want to say, there are many of us here who are medical professionals, physicians, veterinarians, who would know the mechanism, what sepsis does in the body, right? But there are many others out there who might not. So, Prof, could you just give a very, very brief description of the process by which sepsis occurs?
Yes. No, thanks very much. And I think that's a very good. Even the medical profession, they don't really know. What it is, we can get an infection. So we get an infection on the skin or anything, and we put some cream and it's all better. When a bug, any bug, bacteria, virus, etc., enters into your bloodstream, the immune system of all of us tries to fight it off, and most time we are able to. But when the immune system is overwhelmed, the immune system tries to fight this. There's a vigorous response, and then we get a fever, we get chills, rigors, etc. Sepsis then occurs because of this overwhelming response that targets various organs in the body. So you'll have targets your heart, lung, kidneys, your brain, okay? So that's what it is. It's an infection that leads to systemic or symptoms that leads to organ dysfunction, and these organ dysfunction can lead to death. So any infection in the world that goes systemically into the body and overwhelms your immune system is sepsis. Does that make sense?
That's a perfect description. Thank you. I think that would make everybody understand.
I think the other thing I'd like to point out is that a few years ago in Canada, I was asked to do a survey and find out what are the big issues we should be addressing in children. And two came to the surface as the top. One was sepsis, because sepsis involves everybody, human beings, animals, etc. And there are no one discipline, like we have a kidney specialist, heart specialist, etc. Sepsis involves everybody. The second one that came up was pain, and we all understand pain. So this has relevance to everyone on earth and every discipline.
Yes, it does. Thank you so much. I myself was, as I was watching your presentation, especially towards the end, and you were talking about some of the factors that increase the incidence of sepsis, and you talked about, poor nutrition and overcrowding. And I couldn't help but think about in our production industries, when we think about the production of animals, it's the same things that cause the increase in disease incidence in the animals. When you have a goat farmer who has too many goats in the one little pen, then he has more disease happening in his pen. So it crosses the species, humans, animals, everyone. This is definitely a very important One Health topic. And thank you so much again, Prof, for your presentation.
Thank you.
Well, just to say quickly, Kathy, if there are a couple of questions in the chat, maybe Prof can answer them, can type the answers in. All right.
Yes, Prof. Please have a look in the chat. In the interest of time, we do have to move forward.
In the Q&A.
Any questions in the chat? I do see now one from a Michelle Price and one from a Shamar Hutchinson. I will ask if Sam can please put them, or if those people can really put those into the Q&A section so that Prof can answer the question over there. Thank you so much. And let's move on to our next presenter. So our next presenter is Dr. Teola Noel. She is a graduate of the School of Veterinary Medicine, the University of West Indies. She attained a Master of Philosophy in Veterinary Public Health in 2018 and is currently an assistant lecturer in Veterinary Public Health, Veterinary Epidemiology, Food Safety, and Veterinary Bacteriology at the UASVM. Her research interests include human and animal leptospirosis, food safety practices, and geospatial science of animal diseases. She's also involved in working with the local community to restore the buffalypso. Please welcome Dr. Noel presenting leptospirosis, implementing a One Health approach.
Hi, good afternoon, everyone. I hope you can hear me well, and I hope you can see my screen. Thanks for having me here. Very honored to be on this platform with veterinarians, human health practitioners, and other researchers from the Caribbean and all over the world. So I'm going to be talking to you about leptospirosis, which is such a good topic coming second to Prof. Kisson's talk on sepsis, because this is one of the diseases that can result in sepsis and death, and it does cause deaths in our populations, in our countries. So I'm basically going to talk to you a little bit about the epidemiology, how it's transmitted, the role of the environment, which there's a lot of new research going on, and of course, how we look at the One Health approach to leptospirosis for vets and human practitioners. So leptospirosis, as we all know, is a zoonotic infection caused by those pathogenic species of the bacteria Leptospira, meaning that it's a disease that goes from animals to humans, and there are many serovars of Leptospira, and these pathogenic species that cause disease in our human and animal populations. The infection can remain subclinical in the majority of cases of infected people, but there are cases where you get acute and symptomatic infection, and at least 10% of these cases results in death of persons. So infected people who are symptomatic, they often have non-specific symptoms like those found in those diseases which cause non-specific febrile illnesses like dengue, malaria, influenza, Zika virus, etc. And because of this, leptospirosis is often misdiagnosed. So we see in our news reports over the years, more cases of leptospirosis being reported occasionally. We see it in our local scenarios where we have increased rainfall incidents and flooding occurring. We see it globally as well, where you have those incidents of animals and humans coming into contact with contaminated sources of water. And of course, all over the world, leptospirosis it is present in different endemic scenarios. So sometimes you have lots of cases occurring in some countries, and sometimes you have low amount of cases occurring occasionally. So the CDC for leptospirosis, they have designated leptospirosis as a neglected tropical disease because of the impacts on the vulnerable populations and the diverse epidemiological settings that occur throughout countries. It's estimated that more than 1 million persons worldwide will be affected by leptospirosis, with over 60,000 persons succumbing to death per year, and at least 70% of these cases occur in the tropical regions. So looking at a study that reviewed outbreak cases of leptospirosis globally, we see that there is a lot of cases, the majority of cases rather, occurring in the tropical regions, and at least half of those cases would have occurred in the Latin America and the Caribbean countries. And from the Latin America and Caribbean countries, we had at least the Caribbean producing a lot more of those cases, and then the Latin American countries like Brazil showing a lot more outbreak cases and reporting those cases. And then you have your Asian countries, mostly on the coastal cities, that will report outbreaks of leptospirosis. Right, and this is a review done from the 1970 to 2012, which is a little bit old information, but they have shown that in the latter years of this review, they have seen an increase in the outbreaks occurring, and usually it's associated with increased rainfall activities and flooding. So it would be good to get more updated information as to what is the epidemiology of outbreaks occurring throughout the world. So when we talk about transmission, human infection, it's mostly caused through contact with contaminated water or soil, and this gets contaminated from the urine of animals that shed leptospira. So your reservoir animals, your rats, livestock, dogs, and other wildlife species that will occur in the different countries. Leptospirosis is considered an occupational disease for people that handle animals, such as your livestock producers, farmers, abattoir workers, veterinarians, hunters, game managers, animal control workers, scientists, etc. All those who come into contact with host species for leptospirosis. Although it's an occupational disease, it can also occur due to recreational activities. So for example, in 2000 in Malaysia, there was the Eco Challenge multi-sport race, and there was an outbreak of leptospirosis occurring because of this activity. So out of 189 participants, 80 of those persons met the case definition for leptospirosis, and risk factors when the outbreak was investigated, the risk factors were seen to be because of extended periods of time in the rain-swollen Sagama River in Malaysia, from which you can see a participant in this photo here. So we need to be mindful of the transmission cycle of leptospirosis as it pertains to humans and animals, animals being the reservoir hosts that are shedding this organism into the environment and being a source of infection for people. And we do have many reservoir hosts, right? Humans are not reservoir hosts for leptospirosis. Humans are the incidental hosts and are such susceptible to leptospira. But you do have your primary reservoir hosts, which are animals which become asymptomatic and do not show clinical signs or show very little clinical signs, but they constantly shed the organism into the environment, causing a problem for humans. Right, and just to remind everyone of the clinical signs of leptospirosis, right, in the animals and the humans, you're going to see your icterus, your depression, vomiting, anorexia. You might even have bloody diarrhea. For humans, you're going to have fever, headaches, myalgia. So it begs the question that, you know, the clinical presentation for animals and humans might be the same, might be different. Do doctors think about leptospirosis when the human patient comes to you with fever, headaches, etc., and even jaundice, right? It may be a top differential for veterinarians, especially when there is a history of rats and flooding, etc. But we need to ask ourselves, when does leptospirosis become a differential on our list when it's presented to us? So some of the pathology as well, you have the main pathological lesions caused by liver damage and kidney damage. You have those lack of adhesions between your hepatocytes and acute tubular necrosis and interstitial nephritis occurring in your kidneys. And eventually the patient, when this happens in acute leptospirosis, you have sepsis and multi-organ failure and death occurring. Or when it's a mild infection, you can have recovery and recovery with or without chronic infection, depending on the host being infected and the serotype. So the chronic infection stage of leptospirosis, remember this is crucial as it presents the organism into the environment and causes a lot of human and animal cases. So the immune response clears the bacteria from the host body in almost all of the tissues except the brain, eyes, and the kidneys. And the infection of the carrier animal, it's similar to a susceptible and vulnerable host, except that the leptospires, they manage to successfully persist in the renal tubules of the animals. And these animals may show no signs or show very few signs. So your true reservoir hosts, they are asymptomatic infected animals that maintain and occasionally shed this bacteria into the environment. So your chronically infected animals, these reservoir hosts, they play a major role in the environment. When the leptospires are shed into the urine, into the environment, and then you have the cycle of infection occurring in other animals and people. So this now leads us into the role of the environment, which is a growing part of the research of leptospirosis globally. So there's been a lot of research being done into the role that the environment plays specifically into leptospirosis. And we historically think about the human and animal relationship as it pertains to lepto. But the environment also plays a role, and this can be supported by new research that shows that the soil can play a role in supporting environmental cycling and transmission of this leptospira organism, the pathogenic species especially. So the environment could be considered a reservoir or at least a temporary carrier of the pathogenic strains that cause disease. And it could also be show us that leptospirosis could be an ecosystem-borne bacterial disease. You know, something that we don't really think about the environment being a source of infection. So what the research has shown is that soils of high organic matter content and moisture do play a role in maintaining and harboring pathogenic leptospira. So for example, Leptospira from the serogroup Pomona has been shown to survive for up to 193 days in water-saturated soil. But when there's not so much water in the soil, it only survives for 5 days. Clay soil also has the ability to absorb proteins and organic matter, which now presents this favorable conditions for these pathogenic species of Leptospira to persist in these types of soil. There's also been shown that other parameters such as soil pH, salinity, temperature, and other microorganisms also play a role in maintaining pathogenic Leptospira in the environment without any host species. What's also interesting that is being shown is that Leptospira does show a biofilm lifestyle, and this is where you have bacteria adhering to one another and producing a protective extracellular matrix around its body so that it produces this protective mechanism against harsh stressors in the environment. So for example, UV radiation, salinity, pH, as well as protection from some antibiotic material as well. Right, so this is very interesting to note that Leptospira can produce this sort of biofilm lifestyle as well. So with all of these bits of information and new research, we need to start thinking a little more holistically about the role of the environment, because we have so many different scenarios presenting for leptospirosis locally, regionally, and around the globe. Right, so yes, we have our livestock workers, our pet animals, reservoir hosts being sources of infection, but the environment does play a role with the absence of some of these reservoir hosts for some period of time. So we need to think about that as clinicians. If we don't have a case of flooding, don't have cases of rats being in our history when we meet a patient, we need to think about the environment could possibly be a source of infection, and we need to look for this type of infection when it comes to diagnosis. So when we think about how leptospirosis occurs in our populations, we see that infections of leptospirosis through the environment could be linked to our socially disadvantaged populations, our vulnerable populations, and of course, social inequality. So our persons like our rural farmers, people who are in poorer and poverty-stricken conditions, those who are exposed to inadequate sanitation, poor funding resulting in those sanitation infrastructure, lack of safe drinking water. We all see that this is linked to the incidence of leptospirosis occurring in these different societies. So these are what we need to think about. So we see that this occurs, and this can make more increase in poverty. So we could see that leptospirosis can result, and it can also cause poverty to increase in our socially neglected societies. So when we think about our future trends and how this will impact on our societies, like urbanization, right? Urbanization is increasing, and this is only going to make the effects of leptospirosis worse. So it's going to increase the incidence, and you're going to have more and more socially economic disadvantaged communities affected by leptospirosis. Climate change as well. Leptospirosis is a climate-sensitive disease, and it will likely further increase its burden in the coming decades, right? You have increased adverse weather patterns and disaster events occurring that we have been seeing recently, and this is all going to increase the incidence of leptospirosis occurring in our human and animal populations. So this is where we need to have our holistic approach, and we need to think about the One Health perspective. We need to have our human doctors, our veterinarians, other workers, the farmers, the environmental scientists, soil scientists. We need to have healthy animals as a result of all of this. So what is the holistic approach? So the human health, animal health, plant health, ecosystem health, and biodiversity must all be addressed in terms of the health protection on a global scale. There are lots of challenges and gaps in the information for understanding how leptospirosis occurs in our region, right? So we lack some information on the risk factors for outbreaks, the determinants of the magnitude of the outbreak of leptospirosis, the options for early detection and prediction of when infections will occur, laboratory capacity for diagnosis, reporting of confirmed cases, case data collection, characterization of outbreaks and how they occur. These are all important bits of information, and these are some of the lacking data that we have in our region. And this is important that we get this information out there. So diagnosis is very important in knowing that we deal with this disease. A lot of times our clinicians, our veterinarians may not be able to perform a diagnostic test due mainly to availability and affordability by the client. So diagnosis might be done by a history of rats in the area or flooding events occurring, right? And also a resolution by treatment. But there are diagnostic tests that are available, right? So your gold standard test remains the microscopic agglutination test, the MAT test. Although it might be very resource intensive, it may not be available in all countries. It does detect the infecting serovar and can tell if there is a current infection ongoing. The ELISA testing, it's usually done for emergency cases and can give a very quick result, and it's easily accessible. It's usually based on an IgM antibody test. However, it can give you false positives if the IgM antibodies do linger past infection. It can give you a false positive, making you think that it's a current infection when it's not. Right? You also have polymerase chain reaction, which is also a very sensitive and specific test. However, it may not be available to all countries. Not everyone has a lab that can do PCR. Similarly, dark field microscopy, it lacks the sensitivity to diagnose, but it's very easy to visualize the organism using a dark field microscope. However, not all labs would have such a specific instrument. Right, so diagnosis, there are tests available. However, the accuracy and the accessibility remains the challenge in our region to have leptospirosis detected. So we need to think about the case presentation. We need to have a holistic approach to the history of the case that is presented to us, whether it's a human case, whether it's an animal case. We need to go beyond the source of the animal, infected animal on our reservoir host. We need to think about the environment and what are the conditions that cause exposure to the case that is before us. And we need to also include leptospirosis into our diagnostic approach as well. Laboratories, we need to have capacity and accessibility to veterinarians and human doctors for detection of leptospirosis. We need to have surveillance activities as well to detect the types of serovars that are occurring in our environment. Research needs to be done, and usually these molecular work into serotyping and detecting which serovars are present is done through research projects. So we need to have collaborations with scientists globally. There are lots of work being done all over the world, but there may not be so much being done regionally in the Caribbean. So we need to get on board with, what is being done, because most of these cases occur in our tropical region and in the Caribbean and Latin America. We need to have information sharing. We need to have all stakeholders involved. So the type of serovars that are found, we need to send this out to all of our clinicians, all of our policymakers, and interpret what this information means to the way that leptospirosis occurs in our environment. In preventing this disease, leptospirosis is a very preventable disease. We need to have information systems that integrate human and animal leptospirosis information to all of our stakeholders. We need to have surveillance activities being routinely performed and information being collated and integrated so that we can use this information to make better and informed decisions. We need to communicate this information to our stakeholders, right? So our policymakers, our clinicians, our animal workers. Everyone needs to know what is the current information, what is the scenario in our country or in our region. Vaccination is very important. We need to keep promoting vaccination. Leptospirosis is a serovar-specific disease, so we need to ensure that the animals that we are vaccinating, it does include the serovars that are found in that country, and make sure that we are preventing those leptospires from affecting these susceptible animals. And of course, this type of information does rely on surveillance activities that needs to be conducted. We need to know how we're going to mitigate climate change and its effects, right? So we're seeing a lot of disaster events, a lot of rainfall, a lot of other types of disasters, volcanic eruptions, earthquakes, and how these impact on our animal populations and our human populations. Prof. Kisson talked a little bit about it. He also talked about people migrating, refugees. Where do they go with their pets? Do they bring their pets with them when they migrate? And all of these things we need to think about. Are these animals being vaccinated? Are these animals given veterinary care? they can be a source of leptospirosis infection and a spreading of different serovars into different regions. So we need to think about mitigation strategies for different types of disasters that occur. So leptospirosis is a treatable disease. Of course, there are standard antibiotics and dosages that are used to treat leptospirosis, and of course, supportive measures that are used. Selection is based due to the animal or person that is infected. And of course, we have to think about the risk of antimicrobial resistance, which seems to be an increasing issue that is occurring currently. So we need to have a multidisciplinary approach through communication, education, and training. We need to raise awareness of every person about the rational use of antibiotics, because if we don't be mindful of how we use antibiotics, leptospirosis will not be a treatable disease. So I just want to enforce the One Health concept. Leptospirosis is a very easy example of how we need to collaborate and work together. Our animal health workers, veterinarians, farmers, all the stakeholders involved with our human clinicians and those involved with those human cases and the environmental scientists, etc. We all need to communicate, coordinate our activities, share information, and collaborate for better decisions and policy making so that we have healthy humans and healthy animals at the end of the day. So I'd just like to share these are some of my references. And I would also like to thank the School of Veterinary Medicine, some of my supervisors, Professor Kisson, current supervisors, Dr. Carla Georges, Dr. Lisa Benjamin, Professor Chris Ura, and Mrs. Alva Marie Stewart Johnson, and they are crucial in spreading the word of leptospirosis and working on increasing our diagnostic capacity locally and regionally. So we do remain as a place of support for veterinarians and human clinicians. So you can feel free to use this email and contact us if you have any questions about diagnosis of leptospirosis and research and collaborations, as well as the Tropical Medical Cluster of UWI St. Augustine. You can please look at our website, and we've done a lot of research on leptospirosis for over the years. All right, so thanks very much for listening, and I will take any questions at this time.
All right, thank you, Dr. Noel. Long time no see. I do have a question in the Q&A for you that says, can birds, whether domestic or wild, spread leptospirosis?
Birds don't seem to be a host for leptospirosis, or at least a major host for leptospirosis. And of course, we need to have more research being done, more surveillance to know what is the incidence of birds getting infected with leptospires, right? So there's no infection that we know of. There may be very rare cases, but it's not a source of infection. Similarly, for cats as well, there have been more cases in cats, but we don't really hear about cats getting infected with leptospirosis, but it does occur.
Okay, that's interesting, right? Because we say cats are the ones that catch the rats,
Yeah.
and the
Yeah.
rats are the general host. That's interesting. And then I have another question from the chat. I do see your hand, Dr. Cadogan. It says, what is the survival rate for a person with leptospirosis? But I know you're a vet, so I'm not sure if you have the answer so much to that particular question, but I don't know if you...
So it's similar for humans and animals, and if a clinician is in the audience, they can also share, but it depends on the type of infection that occurs. So you have the different stages, the acute, the mild, and the chronic form. So the acute and severe form is the one that causes death, where you have basically within a few days to a week or so, septicemia, multi-organ failure occurring and death occurring, right?
Thank you. And then I see some comments from someone in the chat as well named Paul Brown, who says that climate variables have already been shown to influence leptospirosis cases in the Caribbean and will modulate the virulence of the pathogen. And the main challenges for diagnosis seem to rest in diagnostic capability and political will to properly define the disease as at least a class 2 reportable disease. Okay, thanks, Paul. In addition to that, I do know that vets all across Jamaica, once we do have any kind of positive diagnosis of leptospirosis, we report it. So it's very important for us to report it. Great presentation. I'm just giving you some of the chat comments. If you haven't seen them already, very informative. Thank you. Good presentation, informative, very good. I like to just make sure you get the big ups that you deserve. And also, as you can see, I don't know if you're seeing the emojis, but ladies and gentlemen, thank you for the emoji use. I'm all about emojis. There are the hand claps and the thumbs ups and the hearts. Look at them going. Go, go, go. Love it. Love it, love it, love it. Thank you so much, Dr. Noel. Any other burning questions? Dr. Cadogan, I see you put down your hand. Do you still have your question?
Oh, yeah. I open the mic because I just want, well, first, Dr. Noel, thank you very much. You really nailed it as expected. And I just wanted to mention, the One Health approach in terms of what we do. Dr. Leon just mentioned that reporting, a veterinarian getting out. One of our problems, though, is even though we're dealing with suspect cases, because here we're not getting the diagnostics. They're not available. We used to have MAT available here. We know all the serovirus that were here. We don't know what their prevalence is now. And so my question is about the dog vaccines. We have 2 vaccines available that some have 2 leptospirosis in there, the icterohemorrhagiae and canicola, and there's another one that has 4, the pulmonary and gripotyphosa. And I know some of my colleagues have been reluctant to use the 4 combination because they don't know if those 2 serovirus are really prevalent here. I actually believe they are. Can you say if pulmonary and gripotyphosa are prevalent in the Caribbean?
Well, it has been found in different countries, but it goes back again to our need for surveillance. So, in earlier years, surveillance activities were probably more regular, at least in Trinidad, I know, but I'm not sure what surveillance activities are being done to find out what serovals we have currently circulating. So older information, yes, I could say yes, it has been found. And it has also changed over the years with vaccination. So maybe in the 60s, the 80s, we've had canicola being present, and with vaccination of our pet dogs, we've not found canicola in the early 1900s or so. So we really can't say if currently, those serovals are here or not. So we need to really have our surveillance activities being done. And this will inform our vaccination practices. That's why it's important.
Okay. I see one last question from Debbie Moore in the chat. I'm going to ask Debbie if you could be a little bit more specific. You said, at what state is the vaccine given? I'm not sure if you're referring to dogs or, animals. I'm not sure what are you referring to? That might need a little bit more clarity for us to be able to answer. And if you don't mind putting it in the Q&A, then we can give you a nice detailed answer in the Q&A. But again, thank you so much, Dr. Noel. And I don't like rushing, but I do have to rush because we are so behind time. So thank you so much. Thank you, thank you, thank you. I just want to, again, ask any further questions to be placed in the chat. It was a wonderful presentation, very informative. And I would like to move on to our next presenter, which actually comes from our sponsor. This particular slot, I believe, is for HiPro. So and they have a live presenter as well as a video. So I'm going to go over, I'm going to request that we get that going.
Hey, Sharik, would you like me to play the video first, or would you like to go first?
I'll go first. Hello, good afternoon. I hope everyone is having a good seminar so far. We at Hypro like to place emphasis on prevention as best as we can, as well as we recognize the importance of companion animals, especially when it comes to our mental health. And so today we want to focus on prevention, specifically the prevention of heartworms in our companion animals. We know that heartworms are caused by mosquitoes, and we know that especially in Jamaica, we have a year-round problem of mosquitoes. Presently, I think we're presently having a dengue outbreak. So we definitely have a mosquito problem. And so as we are encouraged to do the different steps to help prevent the spread of mosquitoes, just know that we're also helping to prevent the spread of heartworms to our cats and dogs. But and since we know that the prevention methods are not eradicating the mosquitoes, it means that we have to add preventative products to our animals. And in that regard, we want to mention for dogs specifically HeartGuard, which Hypro carries, a product by Boehringer Ingelheim. And HeartGuard is a bee-flavored chewable tablet that is given to dogs monthly based on their weight, and this helps to prevent them from developing heartworms. For our cats, we have what's called Broadline, which is a topical application. It's placed on the skin on their back. And this is also given monthly for the prevention of heartworm in cats. Again, we want to stress the need for prevention. We know that as the adage goes, prevention is better than cure. We know that heartworm treatment, especially in dogs, is a costly affair. And so we encourage persons to pick the preventative route in giving their companion animals these products, so that we don't have the case of trying to treat heartworm cases. It's rather not nice experience for the animals, and it will definitely put a hole in your pocket. We also want to encourage you guys to, again, bring your animals to a vet clinic. I just heard as just one of the questions a while ago in the chat, Dr. Kathy mentioned, I heard somebody talking about vaccines, and we're just talking about Leptospirosis, which is also covered by vaccines. And so we just want to encourage you, as soon as you have gotten either your puppy or your cat, that you get them to the veterinarian to get vaccinated, to get their preventative medications, so that we can ensure their health as well as our health, especially as they add to our health. All right, and that is my presentation. Thank you very much. Enjoy the rest of your day.
What does it mean to save the world? To be a hero? Is it the ability to do something special and extraordinary? Or the ability to see the special in the ordinary? Is it the way we rise, even when every muscle in our body says not today? Or is it how we silence the voice that says, we've done enough? Is being a hero found in what we wear? Or does it really show in the many ways we care? Does it mean we go above and beyond, across and below, to make sure we can feed everyone with what we grow? Is it how we plow, plant, pray, sweat, sow, and stay, long after the sun has gone for the day? Being a hero is found in the way we do all of this and more. For you, and the Jamaica we adore, for your service and sacrifice, Hypro salutes you, our heroes.
Thank you, thank you, thank you. All right, I actually saw some questions in the chat, and I tried to answer as they went along. Someone was asking about if the HeartGuard is sold over the counter. I don't know if you're still there, Shari.
Yes, it is sold over the counter. But we also recommend, especially if you have if you don't have a puppy, that you get your dog tested at a veterinary clinic so that you can be sure that they do not have heartworms before you start them on the HeartGuard tablets.
Right. So if the animal hasn't had any heartworm treatment, if it's an adult animal that hasn't had any heartworm treatment for greater than 5 months, they ought to be tested before they start the preventive. Thank you. Thank you so much. All right. Very good presentation. I'm seeing good presentations for the sponsor there too. So good job. Thank you, Mr. Lewis. All right, let's move right along, ladies and gentlemen. Oh, I see another message in the chat. Denise Simpson says, I did not know that mosquitoes give heartworms in dogs and cats, so that was informative. All right, glad to know, Miss Simpson. Dr. Simpson, glad to know. All right, the rat lungworm, Angiostrongylus cantonensis in Jamaica, clinical aspects in humans, is a presentation that's going to be given to us by Dr. Tracy Evans Gilbert. She's a pediatric, tropical medicine, and public health consultant at the Cornwall Regional Hospital in Jamaica. She's a senior associate lecturer at the University of the West Indies, a clinical assistant professor of pediatrics, and a preceptor in tropical medicine at West Virginia University. Her clinical and public health research focuses on childhood infectious diseases, which includes a review of clinical manifestations of the rat lungworm in Jamaican children. She has contributed to reviewing technical guidelines and book chapters for the Jamaican Ministry of Health and is a technical advisor to PAHO on immunization. She is a past president of the Pediatric Association of Jamaica and a member of the American Society of Tropical Medicine and Hygiene and the European Society of Pediatric Infectious Diseases. Please put your emojis up for Dr. Tracy Evans Gilbert.
Okay, hi, good afternoon, everybody. Thank you so much for inviting me to speak here. This is a very, very interesting topic because I met this worm many years ago, and I am going to share with you what has transpired since then and what you can learn from this fellow and his mate. So I'm going to just go through the biology, the geographic spread, have a look at the life cycle, share with you what's happening in Jamaica or what my experience with children with eosinophilic meningitis and angiostrongylus, and just take you a walk through if you meet somebody with angiostrongylus, what they might look like clinically, how to diagnose it, how to treat it, and how to prevent it. Excuse me. So it's the rat lungworm. Is classified, it's a nematode from the superfamily Metastrongyloidea and the family Angiostrongylioides. And that group of families, there are about 20 species, but only 2 of them will cause disease in humans. And one is the Angiostrongylus costarricensis that causes abdominal angiostrongylosis, and that's mainly in South and Central America. And we're going to be focusing on the Angiostrongylus cantonensis, which causes eosinophilic meningitis. Now, let me just move this over here. So basically, this is a map that is showing us the distribution of animal and human neurological angiostrongylosis. Historically, let me just get the pointer here. The first identification was in China in a rat. So the angiostrongylosis was found in a rat in 1933. And then about 1944 in Taiwan, there was a case of eosinophilic meningitis. Since then, the cases have moved east to some of the Southeast Asian countries, then westerly to some of these Pacific islands, and then to the south in Australia. And then World War II happened, and missions moved across the globe. And so cases started appearing in America, the southern part of America. In the Caribbean, Jamaica, we had some cases in Jamaica. Some tourists came in 2000, about 12 of them left here with eosinophilic meningitis after eating contaminated vegetables. And there's some other Caribbean islands, South America, Africa, and parts of the blue dots represent non-endemic areas. And that is just reflection of global health and people traveling. Now, I noticed a lot is being said in this conference about climate change, and you need increased rainfall for one of the intermediate hosts to flourish. So over time, climate change may impact the presentation of this disease, and we're going to have more global effects. So this is one of the diseases to watch in the future. So the main host is the rat. Here, he's a definitive host where most of the life cycle occurs. The intermediate host is the snail. And then you have these two other hosts, a paratenic host and an accidental host. So the paratenic host, this is like crabs and shrimp and frogs and lizards. And these are like reservoirs. They hang out in these guys. And the parasite does not, multiply in these guys. And they also can be found in when the snail crawls on vegetables that you don't wash properly. And then the accidental host can be humans and animals. So for the veterinarians, you will see, the impact of it in the dogs and the horses and the primates. But these are dead-end hosts because the organism doesn't mature and you can't pass it on to another person or animal. So to complete the life cycle, you need two different hosts. You need the definitive host is the rat, and then the snail or slug as the intermediate host. So essentially what happens is that this here is a picture of the rat's lung, and that's why it's called a rat lungworm, because this is the adult worm in the pulmonary vessels of the rat's lung and the right ventricle, and they can grow as long as 1 to 2 centimeters in the males and 2 to 3 centimeters in the female. So starting the lung, these adult worms will lay their eggs, and then the eggs will go through the bloodstream, and then it will hatch to the first stage, and then it will penetrate the alveoli in the lungs, then goes up to the trachea, swallowed, and then it goes in the poop and passed in the feces. And then the feces would then, containing this first stage larva, will go through 2 different more molds to a third stage in the snail or the slug. And then another rat will eat that snail and complete the life cycle. It will then penetrate the bloodstream, go to the rat's brain, mature to the adult stage, and then the adults will move to the bloodstream and then go back to the pulmonary artery, where the cycle goes all over again. And this life cycle takes about 4 to 5 days. Now, once it is in that intermediate host, that is when the accidental host can get that third stage larva, either from ingesting raw undercooked mollusks that have the L3 larva, or having fresh produce that was contaminated. And as I said before, in the 2000 outbreak in Jamaica, 12 North American tourists were infected by ingesting vegetables. The other way that human hosts can get it is if they eat undercooked crabs and shrimp, or they eat frogs that aren't cooked properly. Some people eat frogs. And basically the life cycle will continue just like it did in the rat, where it will, I'm sorry, I'm being called, sorry. Where it will then go into the gastrointestinal tract, cross through the intestinal wall, go into the bloodstream. Some might go to the lungs, but most will go to the brain and cause eosinophilic meningitis. So essentially what we're seeing here are different hosts, but in humans and animals, they become the accidental host of this Ancylus strongylus. And essentially what happens is that it's alive in your brain or other parts of your body, and movement, plus when they die, it has an intense inflammatory reaction, which is what is responsible for the symptoms that we have here. So for the human infection, they come, the incubation period is about 1 to 3 weeks, with a range of 1 day to 6 weeks. And most of the worms cannot re-enter the circulatory system, and so they die in the brain tissue. And the symptoms can go on for quite a long while, as you can see in the case that I'm going to present in a minute. Can be observed up to 2 to 8 weeks, but in the more severe cases, it can go a little longer. And if you have severely affected patients, they can have permanent neurological deficit. So this one little worm can cause a lot of damage in humans, in human hosts. So when I was a resident, I came across these little fellows in the CSF of one of my patients. And this paper was written following that, because I went looking for this germ or this worm across the island to see who else have been affected and how they were affected. So I'm going to present the case that I was introduced to back in, I don't remember how long back this was done. So there was a previously healthy 19-month-old child from rural Jamaica. She came to the Bustamante Hospital for Children, and she had a 1-week history of refusal to walk, excessive crying, and 2 days later, she refused to crawl. She was a healthy child, antenatal, normal age-appropriate milestones. She was immunized. There was no trauma, no medication, no infectious symptoms, and no familial illness of neurological disease. And all of her 3 siblings were ages 3 to 6 were all perfectly fine. And she, was a healthy, nutritional child, no dysmorphic features. And the mother told her she was very irritable when she handled her lower limbs. Her muscle was weaker. She was a little floppy. And, when you touched her, she was just very hypersensitive. On the 3rd day of admission, she developed meningism associated with fever, runny nose, and cough, and a high temperature. Now, this is where the exciting part happens. On Ward 5, I can remember it like it was yesterday. So the intern uses a 25-gauge needle to do the lumbar puncture, and then I heard this huge scream. I go into the side room, and there in the CSF tube were 6 to 8 worms wriggling around in the CSF. That was not normal. But when we analyzed the fluid, there was a 20% eosinophilia, normal proteins, and the glucose ratio was okay. The parasitologist, Dr. John Lindo, helped us with this case, and this was identified as Angiostrongylus cantonensis. There were male worms hanging out in this child's CSF. They had Toxocara and Tenosolium by serology, and all the child's cultures were sterile. This is one of the guys of the 6-8 worms that were there that were removed, and this was some particular feature that showed that this was a male worm. So anyway, I got really excited about this, and this patient was a very challenging case because the symptoms went on for several weeks. Fever up and down, we're doing serial LPs, it still had eosinophils, and at that time, the management for this was just to do serial LPs to relieve the headache, and they were saying, don't give antihelminthics, because if you give antihelminthics, you're gonna make it worse. And I said, how much worse can it get? This child the symptoms are progressive. One day she has one neurological symptom, the next day she had another. And basically, I read through the literature, I looked at Taiwan and all the cases, and I found that in Taiwan, they gave the albendazole, but they gave it with steroids. And that is exactly what I did. And she recovered, but she had long-term sequelae. She was cortically blind. She had 4th and 7th nerve palsy. So she did have some sequelae. The other children that we found across the island had similar features, headache, fever, irritability, just like you have with meningeal signs. But the CSF showed mainly eosinophilia, which made the diagnosis. And one of the children, who was a 12-month-old child, developed a hemiparesis, but all the other children recovered. And at that time, once the case was mentioned to me, we would use the similar management, and those children recovered without sequelae. Then I started looking for other kids in the world who presented like this, who presented severely. And most of the children who died had bulbar involvement, meaning the worms were hanging out in the bulbar area, and so they would affect their breathing, they were put on a ventilator and die. Particularly and notably, the last case that you see here, done a 14-month-old child, this was a Jamaican child, died. He was on ventilator and died. And when they did the post-mortem, they found dead and viable worms in the baby, the worms that were still alive. And that made me even more convinced that these children needed to be on antihelminthic because the worms were still there in their brains. So what was noteworthy was none of these reported cases globally were received, the ones that died anyway, received albendazole, and they were just getting supportive care and multiple lumbar punctures. But I mean, the evidence was showing us that there was live worms that needed to be killed. And so even though I didn't have any evidence, this is what we used subsequently for any children who had similar features. And of course, the fear was that the dead worms would cause intense inflammation and make it worse. So what we did was gave it with steroids at the same time. Anyway, so the public health went to this baby's home. They found all these Leptospirosis asperus snails, and this was the main intermediate host for A. cantonensis in Jamaica. And it's possible that this is a 19-month-old, they're crawling around, pick up something, pop a snail in your mouth, not thinking about it. And we're thinking that based on the body surface area ratio, there's just a high burden, the immune system is different, and so the patient presented severely. So in the case of, a suspicion of eosinophilic meningitis, everybody on here is not from Jamaica, but you'd need to think of a history of possible contact with snails or slugs. Sometimes it's just somebody daring somebody to pop that snail in your mouth, or unintentionally they popped it in their mouth. In some countries, they do have it as part of their dietary plan back in the Southeast Asian countries. So there might be a history of eating uncooked snails or inadequately washed vegetables and fruits. And if you didn't cook your shrimps and your crabs and stuff properly, those could have been hosting the Angiostrongylus. And potentially contaminated beverages, yum green smoothie with some crushed up slug in there or some slug slime. So, guys, just be careful that your vegetables are very polished and washed, and the source from which you are taking these things. So another thing that you need to think about is the travel history. It's endemic in Jamaica, but if you're, thinking of somebody else, think of places that they may be coming from on that side of the earth, Southeast Asia, China, Taiwan, Australia, are some of the places that they could be going to, South America and parts of the United States and Africa. And the evidence is showing us that there is possibility that the geographical range is increasing, maybe climate change, maybe or it's just, travel and global changes. So essentially, as I mentioned before, the organism, pretty much just like the rodents, where it has that life cycle in the rodents, it's similar to the excuse me. I'm going to call it back. I'm giving a presentation. I'm going to call it back, please. All right. So sorry about that. So, right. So basically the larvae, once you pop it in your mouth, it goes in your gut and it crosses your intestine, goes into your bloodstream. And so you can get all of these different symptoms. The main one is the CNS symptoms, but you can have generalized symptoms, fever, malaise, body pain, and fatigue. And the GI system symptoms might reflect when the larvae penetrates the gut, and so you get some GI symptoms, vomiting, nausea, abdominal pain. And the worm can go into your eyeballs, which I'll show you in a little later. And few patients may have airway problems, which my child had. She had some cough and rhinorrhea as well, but her primary symptoms were in the CNS. And so not everybody presents with severe signs. Some maybe just present with non-specific symptoms. In fact, somebody may have it and don't even know it. But over a week or more, the symptoms will evolve with more signs appearing. And if you're looking for it, some patients actually present with a rash, myalgia, and arthralgia. But it is when the cases are severe that you see the neurological findings that suggest that the patient has eosinophilic meningitis. As I said, you'll have that GI prodrome because of the L3 larvae is gaining access to your circulation en route to the CNS. And people may be asymptomatic for quite a while, maybe up to a month, followed by the appearance of headache and other neurological signs. And as I said, they're mainly CNS, headache, fever, nausea, vomiting, photophobia, and then more suggestive ones, which are headaches, the paresthesia, the itching, the hyperesthesia, like what my patient had when you touched her. She was very sensitive, tingling and crawling and burning sensation, and bladder and bowel difficulties and seizures. Children tend to have less of the paresthesia. They're more irritable. My little girl, she cried incessantly because there were worms crawling around in her brain. She was just crying like crazy. She was probably having severe headaches, and we did serial LPs to help to relieve that. She didn't have any seizures and no muscle twitching. And in children, they're more likely to have meningoencephalitis and 6th and 7th cranial nerve palsy. And my baby had 6th and 7th cranial nerve palsy. Physical examination, focus on the neuro, focus on the eyes, because those are the two places where the worms will manifest the symptoms, looking for neck stiffness, motor and sensory abnormalities, and it might involve multiple dermatomes, and cranial nerve 6, 7, and 8 will might be infected. And of course, you may have some other features if the bulbar area is involved, that's involves cerebellar signs, or you may have respiratory suppression because of where the worms are present in your brain. There are other things that cause eosinophilic meningitis, but Angelus strongylus is the most common cause. There are other non-infectious causes like VP Schwanz lymphomas and intrathecal contrast material. And these other groups of parasitic organisms are responsible as well, but not as common. How do you diagnose it? Well, it's made on clinical grounds on a triad of findings. You have the characteristic symptoms and signs, which are CNS signs. Eosinophilic meningitis on LP, and eosinophilic meningitis is diagnosed as to more than 10% of eosinophils in your CSF. Usually a protein might be elevated, glucose normal, cultures are negative. And then they may have an exposure history, either ingesting a snail or something, or a history of travel to an endemic area. Other additional tests you would do would be your complete blood count. You can have eosinophilia, but it doesn't usually match the degree of in your CSF. And there are other tests that can be done. Serological tests are not recommended because if you're in a low endemic area, you can get a false positive result present. And then there's the PCR test that is also available, but it does not necessarily need to be done because the eosinophilia is the clue, but the PCR will help you to determine if it's the Angelus strongylus that's present. So the CSF here is just showing you the eosinophilia present in your CSF, and the arrow is pointing to what the eosinophilia looks like. And then the confirmatory test is a real-time PCR test. And this can be negative initially, but if you have a high index of suspicion, you can repeat the LP 5 to 10 days later, and you will see that in a eosinophilia in your CSF. Radiological testing are not really necessary to demonstrate if it's present, but what you will find is leptomeningeal enhancement, either in your brain, or if the patient has spinal symptoms, a spinal MRI would show the enhancement. A CT brain is completely useless, and you will see these white matter flares and these nodular lesions. And some persons have chest findings, and you may consider doing a chest CT as well. And this is what the CT scan might show. So in the arrows are showing some leptomeningeal enhancement, and the sagittal section of your spinal cord is showing you the leptomeningeal enhancement there. And this is just the inflammatory reaction to the worms that have made their way into your brain and your spinal cord. Some people get it in their eyeballs, in the aqueous humor, in the vitreous cavity, in the subretinal space. The worm might be crawling right across your vitreous right there, as you can see in this diagram. And for the patients with the oculus Angelus strongylus, it's actually rare, about 1% of the cases. And the worm gets there through your retinal artery. So it will crawl up into so basically you ingest it, crosses your gut, goes into the bloodstream, gets into the vessels, make its way up to your brain, and then it accesses your eyeball through the retinal artery. And with the ocular Angelus strongylus, you can have eosinophilic meningitis occurring at the same time. And they will present with blurred vision, blindness, color vision, redness, or pain, or the sensation of a worm crawling in the eye. So if there's any eye doctors here, if somebody says a worm is crawling in your eye, please have a look. They're probably right. So usually the management is to remove the worm and use local and systemic steroids, or they might kill the worm with laser therapy before they surgically remove it. But in this case, the antihelminthics cannot be used alone as was thought in back in the day, because it can trigger an acute inflammatory response. And an ophthalmologist needs to be let them refer to the ophthalmologist for additional procedures such as slit lamp examination. How do you manage these patients? These are for the modalities: serial LPs, corticosteroids. As I said before, antihelminthics back in the day was not the norm, but now they're saying, yeah, let's use it. And acute pain management. So the lumbar punctures should be performed as often as necessary. Actually, usually when you're doing your lumbar puncture, if you can measure the opening pressure would be high. And it will indicate, that you will need to continue doing the LPs to relieve some of that pressure dictated by the patient's symptoms and signs. So that's the best treatment option for those who may not be able to take high-dose steroids. And this high-dose steroids is recommended for 14 days, and it was found to significantly reduce the headaches. And they give them a dose of 60 per kilo per day of the prednisone, or 10 to 20 milligrams per kilogram of the dexamethasone. That's for 14 days. And for the children, they get the steroids for the 14 days and corticosteroids. And I'm proud to say this is what we did for our kiddo. Thank God for the internet. Well, we didn't have internet. Did we have internet then? Yeah, must have. Anyway, I found a paper in Taiwan, and that's how I was able to know what to do, because none of the American literature had anything. And I had to go to the source where they had the most cases, and we used it, and we continued to use it, even though the literature was saying do not use the albendazole. We very much used it because we saw that the child was progressing. Anyway, so you give the steroids for 14 days, and you give the albendazole concomitantly for 14 days, but you taper the steroids afterwards and monitor for complications of steroids, such as diabetes. So for decades, they were saying that if you kill the worms, you're going to damage the patient with an inflammatory reaction. And now there has been a consensus recently that antihelminthics are useful if administered soon after the central nervous system. And when they're used, it's preferred to use albendazole because it has higher concentrations in the CNS, and thiabendazole has not been shown to have any effect. And it's ideal that it's taken in the first 2 weeks because it will limit the chronic sequelae of the disease. And these are the doses that we are recommending, that have been recommended now for the treatment. And of course, you have to monitor for rare idiosyncratic reactions to the albendazole, so do your LFTs and CBCs and monitor the patient. For the pain control, large volume LPs help with the pain. High-dose steroids will reduce the number of lumbar punctures. NSAIDs, they said, because you're taking the high-dose steroids, you might get a gastritis, and opioids is really not recommended because it can cause confusion, and you don't know, you want to monitor their CNS effects. The long-term sequelae, most people will get better. They have a headache for weeks and weeks, and it goes away. The brain, the worm dies, the inflammation goes away, and they're okay. But patients can develop chronic neurological sequelae that adversely affect their daily lives, and they can have problems, with limb weakness, difficulty walking, recurrent headaches. And gabapentin has been helpful, and you might need to refer to a neurologist for pain consultation, occupational therapy. How do you prevent it? Well, if you don't eat it, you won't get it. So keep your garden free of debris. That will provide shelter and hiding places for slugs, snails, and rodents. It is endemic in Jamaica. When Prof. Lindo went about seeking this Androstrongylus in rats, he caught a bunch of rats, and they had, I think 1 in 5, they found Androstrongylus in the lungs of the rats. So if you're having any fresh fruits and vegetables and citrus and root vegetables, please wash them. Wash your lettuce leaves 1 leaf at a time. You'll never look at lettuce the same again after this picture. And control your slugs and snail pests. And if you're going to handle it, use gloves, please. Finally, vaccines is my area, but there are no vaccines against nematodes. That are licensed for human use. And the main reason for this is that you really can't use a vaccine in a host that's changing where they molt and changing their having different multiple life cycles in different stages in different hosts. And of course, parasites have wonderful immune evasion strategies. and they use intermediate and reservoir hosts. So it's really hard to even develop a vaccine for something like this. And the main thing is that whatever you put in your mouth, just make sure it is properly washed if it is a raw fruit or vegetable. And that's my presentation. Thanks for allowing me to share my exciting worm story. Thank you.
Wow, 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 wow. I was about to go for my dinner. I've changed my mind. Dr. Evans Gilbert. Wow, I can tell you, the chat is full, the Q&A is full. I don't even want nobody ask no more question, right? Let us see if I can go through this chat. I mean, even while you were talking, I'm over here. I can't help myself but emote. I'm going, oh.
I saw all this.
I'm like,
it was pretty weird seeing worms coming out of the needle. It was not exciting, but it was exciting, but it was pretty weird and bizarre.
All right, so let's start with these Q&A questions. Priscilla Robert, I'm hoping I'm at the top. Priscilla Roberts Spence, children lower than 2 years are often infested with worms. Why is it that the anthelmintics are not recommended until 2 years and older?
Okay, so that is because of the side effects, because the drug companies made the drugs as a special dose that is recommended for a certain weight, and the children under 2 are not at that weight. But there actually is a dose adjustment that can be done without bendazole. So if you do have a child who has a helminthic infection, they wouldn't get the full dose. I think it's like 10 milligrams. I'll have to check, but there is an adjusted dose that can be given. And the main reason you're not getting it is because of the clinical side effects that they expect with the preparation that the pharmaceutical industry makes.
Okay, that's very helpful. So for those doctors out there who may want to think about utilizing it, all you need to do is really get that dose weight calculation done, and you should be able to utilize it in those children that are under 2. I love that. All right, next question. Does washing vegetables with salt kill the eggs and stop the possibility of ingesting the eggs?
Right. Just getting them off your vegetable. I don't know if it's salt has any additional benefit, but it's really just thorough washing. Thorough washing. Basically, so what they recommend is that when you're washing your vegetable, put the vegetables under a flowing pipe, and instead of just the slapdash that we normally do.
Right. Right. Don't swish it around in a bowl.
Yes, exactly. Wash it
or
properly.
swish it and then wash it, whichever one.
Yes.
All right. Johannes Rodriguez says, is the incidence of A. cantonensis higher in countries with fried cuisine, French cuisine? I'm not sure.
Okay,
where snails, frogs, veggies, shrimps are eaten in many ways.
Right. So part of it has to do if Androstrongylus is endemic. So not all slugs and snails will have Androstrongylus. So they can eat a bunch of it in their country, but they won't have it because that's not endemic in their country. So it really is dependent on the endemicity of the larva. And so I guess some of these edibles, these delicacies are reared in special places, and they don't pick it up off the street kind of thing. So
right.
So that's not the case. It's found in tropical and subtropical countries usually.
Okay. All right. Lisa Campbell Plummer asks, does giving worm meds periodically to children and adults help? So this Jamaican culture where every September,
worm out.
Back to school, they get a worm out.
Okay. Well, the medication that helps with neuroandrostrongylodiasis is not the medicine we give the worm out for the kids, because it's albendazole and it's for treatment, but it's not for prevention. And the studies have not really demonstrated that it has a preventative benefit. The worm that they give are more for like the hookworm and these other ones that are more prevalent in
right. Okay.
But it's not a preventative measure that is known to be that's recommended.
Wow, so many questions. Why is the PCR diagnostic test necessary, I guess, if the worm can be visualized directly?
Not everybody will have a worm crawling out of the tube. That was just a lucky shot. And I need to find that intern and see where he is in this world today. But yeah, that was a fabulous LP. But usually what you find is the eosinophils in the CSF. And once it's more than 10%, then you you can make the suspected diagnosis and start the treatment right away. So the PCR is not a must, but it's helpful if you want to confirm. It's a confirmatory test. That's the word I want to use. It is a confirmatory test, but you don't need to wait on it to proceed with your management. If you have the signs, you have the eosinophilia, and you're in an endemic place, or somebody come from an endemic place.
Okay. And is the risk of permanent complications linked to any immediate finding? Example, severity, the length of disease duration, bulbar involvement?
Okay, so we think that, or this is the thought, that is due to the burden of the disease, to burden of the worm. So if you eat one that has a bunch of Androstrongylus in it, then the worm burden is going to be higher. So for example, in the children, because their body surface area is smaller than an adult, if they pop one of those guys in, the burden is going to be higher, and so that's why they have severe manifestations.
Right.
So we think it's the worm burden that determines the outcome of severity.
Okay. Odette Wilson asks, is the blindness reversible?
No, so our child developed cortical blindness because of damage to the brain, but most of the people who have the worms crawling through their vitreous or on the conjunctiva, they just remove it and their vision is returned.
Oh, nice.
But if the worm is crawling through your brain and affects your visual sense and scars it, you can have permanent problems, as in the child we had.
Camille Hines is asking, which local species of slugs/snails are vectors for the lungworm?
Okay, so I had mentioned in the presentation which one it is, and it's a very long name, but so it's endemic in Jamaica, and I had the name in the presentation, which I cannot remember right now because it's a very long.
And Camille, you will get the presentation, so no worries.
Yes, you can have my presentation, no worries, all free.
All right, wow, guys, there's so many more questions about the prevalence. How prevalent is it in Jamaica?
The prevalence is really, I can tell you the prevalence in the rats. It's that doctor.
1 in 5, you said.
Yeah, he said he found 8% in snails and 22% in rats. In terms, it's not common. We don't see it. I haven't seen a case in a really long time, and I found 5 years. So yeah.
All right. So I mean, I'm just gonna skim over some of the questions, but I would invite you, Dr. Tracy, to go through the Q&A. This one, I see something from Dr. Tellez, but that's not really a question. And then somebody asking about cooking, killing the eggs.
Right. Once you wash or thoroughly cook your produce, you are good to go.
All right. So I think we're good here.
Okay.
And I see some of these answers being removed, so because they've been answered live. Thank you so much, Dr. Gilbert. Oh my goodness.
Yeah. I'm sure I've thoroughly scared all of you now, and you're going to look at your food much differently now.
No, but I mean, the love is coming in via emojis and in the chat. It's an eye-opening, wonderful, interesting, informative, excellent, scary, and very exciting presentation. Thank you so much. Thank you. Look at the love. Look at all the love coming up.
Feeling the love. Loving up.
I love it.
All right.
Thank you so much. Have a good afternoon.
Thank you.
All right, ladies and gentlemen, we are moving on. Wow, what a presentation. Now we're going to have a word from some of our sponsors, and I'm going to invite you to sit back, try and recover. Try and recover from that exciting presentation by listening to the sponsors who have helped to bring this conference to you this weekend. Take it away, Sam.
Okay.
Oh, I see Dr. Cadogan is.
Yeah, I think because I have been asked by my good friend and colleague, Dr. Graham Brown, to say a few words on his behalf before our sponsor, his company, Jvma, One Health Limited, before they play their video. So I do not work for Jvma. I am just doing this on behalf of my colleague who couldn't deal with doing it today. All right, so just some opening remarks. One of the major objectives of One Health is to ensure safe and secure food supply for our human and animal populations. And of course, that food comes from both animal and plant sources, and needs to be free of infectious agents and toxins that can do harm. So that means that we need testing, monitoring. It's essential to ensure that our food supply is safe. So Housekeeping One Health Laboratory was formerly Animal Care Veterinary Services Laboratory. It's a company that's owned by veterinarians that provides food safety testing, accredited food safety testing. They're accredited by the Caribbean Accreditation Agency for a slew of tests. It begins with the animals and the environment on farms and continues with testing in processing facilities, ends with the testing of the finished products and environment in restaurants and other facilities where food and beverages are consumed. So what is that? That is the classic food safety dictum, from the farm to the fork, right? The mantra of food safety. And all of this is to ensure that the food we consume is safe. And, many people won't even think that this is what goes on. It's happening there behind the scenes to protect our health, right? And the presence of these harmful organisms or substances on a farm could cause death in a home thousands of miles away. I mean, you import some product that has some contaminant, and it can be fatal, right? So it's because of this integrated One Health approach to monitoring and safety of produce from the farm to the fork that we sit at home and eat and drink without worrying too much about getting sick. So Housekeeping One Health Laboratory would like you to watch their animated video about what they do, and there's also a brochure that we can access that can be distributed through our system here to you all to learn more about what Housekeeping does. So Sam, head with the video.
Hello. Do you know the economic impact of food safety problems on food businesses in Jamaica? No? Well, nobody does for sure. But the estimated cost of food safety incidents for the economy of the United States is around $7 billion per year. And as we develop our food industries in Jamaica, food safety issues are becoming a big problem here as well. Food safety is very important. By improving the safety of your products, you can avoid legal costs due to food poisoning or economic costs caused by food spoilage. And very importantly, you can maintain the reputation of your company and meet international regulations and standards that ensure the safety of the food you supply to your customers. Housekeeping One Health Laboratory is ISO 17025 accredited. We can test for most of the organisms that cause problems with the food you produce. We can test the product, the processing facility, the hotel kitchen, the restaurant, you name it. We can test almost anywhere to identify problems before the problems identify you. And we can do all sorts of other tests to ensure the products you sell or serve are wholesome and fit to carry your logo or to be served to your guests. Thank you for listening to this message. And remember, our laboratory can be your laboratory in a few minutes from now if you call this number.
To be an Olympic champion, you have to train every day. Spikes, gears, bag, oh, forgetting hydration, seatbelt. With my training routine, GKG Online saves me plenty of time. It's the fastest and easiest way to get a quote or your motor insurance coverage. GKG Online, that's it. Yes, really. Click, that's it. It's faster than a 110 hurdle race.
Visit gkgonline.com today.
From run a boat to running a kitchen, there's only one brand, Grace Ketchup. Join the rhythm, enjoy the flavor, the taste that you savor. Share with your friend and your neighbor, the taste that you favor. Join the rhythm, enjoy the flavor, the taste that you savor. Share with your friend and your neighbor, the taste that you favor.
Grace Tropical Rhythm, bigger rhythm with the same vibes.
It's the taste like the beat of a drum that makes you move. From the Caribbean to the world, wrapped in the food. The taste that moves you. Sharing the moment, share it with everyone. The taste that moves you. Come make we share the joy and share the love. When the food's sweet, we dance. When the vibe nice, we love. The taste that moves you.
Nothing moves your vibe, your mood, or your appetite like the taste of Grace.
For breakfast, lunch, or dinner, what we say? Grace might feel like the winner.
Look at the rich, beautiful sauce. It look nice and it smell nice. Great sauce plus great taste multiplied by great value. It's almost an illogical theory. One must be better.
Listen, it's a taste. I consume it straight from the tin.
I tell you, it's a value. It worth every cent.
You don't say taste.
It's a sauce. It's everything. It's sauce. It's taste. It's value. It's all of the above.
Grace bring you the food you love.
The sun isn't up, but you are. On the weathered bench by the door, you put cold feet into muddied boots and look up at another young sky. It's never the same as yesterday, but as you slap your knees and stand, you are ready. Ready to grab the day before it begins, with strong hands that know how to gently cradle new life. It is time. Time to milk the morning for everything. Dig your heels deep into the ground. Wrestle the beast for her own good. Push your weight around so things get done. Time to wait on the rain. Time to wait for the storm to pass. Sometimes you will scream and no one will hear. Then you'll pull yourself together, laugh out loud, share a drink with a friend, stop and wipe your brow. It's tough, and anyone who says otherwise has never really been there. But this is what it takes. And if you are made for this, you wouldn't be doing anything else. Because what work is greater than bringing life back with your bare hands? Feeding your family while the earth supports you. But look, if all this is too much for you, if you want to leave, we understand. But if there's nowhere else you would rather be right now, if you're still here, then we are right here with you. In the pen, in the shed, in the field, and in this moment. We are ready to build, to care, to grow right here. You ready? All right, let's get to work.
that's it for presenters.
Yes, thank you. Thank you, Sam. Thank you to our sponsors again. Oh, I've lost my, where is it? It's not what I was looking for. All right, give me a minute. I've lost my intro stuff. So I'm pulling it up again. Here we go. All right, thank you to our sponsors. Thank you, thank you. Those are excellent videos. Thank you, Sam, for seamless transitions. So let's get right back into it. I hope everybody got a chance to grab something, a little snack too. I was glued to my seat because not only are the presentations good, but even the sponsor presentations are good, and I can't get up. So I'm just here. I'm just here, hungry. So without further ado, let us introduce our next speaker, Dr. Adana, Mahays? Dr. Adana Mahays-Gibson, a veterinarian and graduate of the UA School of Veterinary Medicine, describes herself as a One Health-oriented, mission-driven, brocular and fire starter. Bricolia? I don't know that word. Someone will have to teach me.
Bricoleur, French.
Bricoleur. I have to twist up my mouth. Mission-driven bricoleur and fire starter with 20 years experience in the region. She has worked on climate change, poverty reduction, food security, and other social, ecological issues with marginalized communities, governments, NGOs, and international agencies. She has been a mentor, leader, volunteer, and rabble-rouser. Listen, what is this bio? A passionate anti-racism advocate. She works to tackle neocolonialism and sexism in the workplace. Adana has experience in equity, diversity, and inclusion, project management, adaptive leadership and strategic planning, systems thinking and complexity, monitoring and evaluation for social change, and transformational learning, with emphasis on decolonizing evaluation design and implementation and science communication. Adana is responsible for managing one of the most successful One Health projects in the Caribbean, the One Health, One Caribbean, One Love project from 2014 to 2017, and now works with the EU-funded project Capacitating One Health in Eastern and Southern Africa, which encompasses 12 countries across Southern and Eastern Africa. She's currently the co-chair of the Caribbean One Health Alliance, a network of Caribbean One Health professionals. As such, she continues to support and mentor Caribbean One Health practitioners. Welcome to the Rabble Rouser, Bricoleur, and Fire Starter, Dr. Adana Mahays-Gibson.
Hello, thank you. Let me just share my screen. Can we see?
Yes, we can.
Okay, fantastic. All right, well, let's get started. Thank you for that introduction, and it is a pleasure to be here. How are we feeling except hungry? It's been a long day. So you know what? I'm just going to jump right in. I am doing an introduction to equity, diversity, and inclusion for Caribbean One Health. And I want to acknowledge my friend and co-author, Dr. Roderick King, as well as the contribution of One Health experts, Professor Latifa Hassan from Malaysia, and Professor Wanda Makota from South Africa. Okay, so today's talk, what are we planning to cover today? We are going to touch on a few things. First and foremost, why are we talking about this? And then we're going to look at some definitions. We're going to look at what's happening globally. And then we are going to examine Caribbean One Health using an EDI lens. We're going to talk a little bit about the importance of Caribbean voices and what's next for us. So let's get started. All right, why? Why are we talking about this, people, today? Why is this important? This is because our history matters. Many of us have received sanitized versions of our history, and quite simply, we are not necessarily aware. And like a fish in water, when a fish is asked, "Oi, How is that water? The reply is, what water? We operate in systems that can be unjust and unfair for different groups, and this systemic injustice has become a way of life for us. I'm going to be talking about the CARIFORUM region, which includes Belize, Guyana, and Suriname. And what do we have in common? Well, for starters, we are all former colonies, colonized by European powers, including the Spanish, the Dutch, the French, and the English. And that legacy of colonialism includes genocide, racism, slavery, indentureship, and a whole lot of trauma. The reason that we are talking about this is that if you examine the history of our health institutions, the global health model, and by extension, One Health, they are linked to colonial conquest. Health services during colonial times, for example, were designed to protect primarily the health of European personnel who were essential at that time to the colonial economy. Colonized peoples were considered incapable of improving their own health. And these implicit structures and ways of thinking, they are still in place today. As recently as 5 years ago, we could only whisper these words because there was legitimate fear of repercussions from those in power. So this evolving field of equity, diversity, and inclusion, or EDI for short, it gives a language and a voice to be able to address some of these deep-seated issues and help us chart a path forward. Okay, so definitions. EDI is a rapidly growing field of practice and research. And let's start by diving into some of these terms and concepts. So what is diversity and inclusion? So these terms are used together, but they are actually distinct. And the simplest definition I can find is by someone called Andreas Tapia. He says diversity is a mix, and this mix refers to the differences in social identity, such as age, social class, race, sex, gender, and disability status, for example. Inclusion is making that mix work. It's a verb, an action. It is the action of embracing, enabling, and empowering diversity. So diversity is the what. What is there, that mix? Inclusion is how we get that mix to work. So diversity can be thought of as getting people through that door, and inclusion is how we make them feel welcome. All right, so core concepts, and this is a great graphic that is sometimes used to explain EDI. Let's start on the left here, reality. So this demonstrates how one person gets more than is needed, while the other person, they don't even have a box, and they can't even see over the fence. There is a huge disparity here. So the equality pick is really interesting. When we put equality to the test, there is an assumption that everyone benefits from the same support, that fairness is giving everyone the exact same thing. In this case, when everyone is treated equal and they get the same box, but guess what? A little friend, he still can't see the game. So if equality is not fair, what is equity? Equity means everyone gets the support that they need. It is customized support, and this takes to account people's circumstances. Our little friend in this case gets 2 boxes and now is able to see the game. So let's move over to justice. So while equity might be fair, sure, everyone can see the game, but is it right? Is it right to live in a system where fences keep people out and some people need boxes? So justice is about addressing the underlying causes of the inequality. With no fence, you don't need boxes. And justice means examining the systems, relationships, and power dynamics and asking if they can be changed for the better. So I really like these sets of images because it's a great way to get people thinking and talking. And if we aim for equality, usually we end up talking about equity. And if we aim for equity and we keep asking those questions, we end up talking about justice. So what would we need to change so we don't have to worry about handing out boxes? Okay, a lovely example for equality and equity. I want to zoom in a little bit here. Equality essentially is if I decide this entire room, I want to give everyone a shoe because, you know, we want to be equal here. So size 7 high heels for everybody. Here we go. Now, that's fine. That's equal. Everybody gets the same shoe. Equity is ensuring that everyone gets a shoe that fits, right? And it's customized support. Not everybody wants a size 7 high heel shoe, okay? And my question here, taking this example, takeaway thought for you, what would justice be for the system? Could it be the freedom to choose whether we want to wear shoes or not? You know, food for thought. Okay, some more terms that are used in the EDI space. And there's quite a few, right? I am only going to touch on a few today. And I've included for you and those who are interested some additional resources towards the end. So the term BIPOC is short for Black, Indigenous, and people of color. It is a term used to describe a wide variety of people who nonetheless may share experiences of discrimination. The term ally describes someone who is not part of a group experiencing discrimination, but supports the rights of marginalized people and acts when others face discrimination. So depending on the situation, we can be an ally to someone, or we may need an ally ourselves. You know, and speaking of fences and barriers to inclusion, our everyday language contains some. If we listen to everyday phrases, for example, we may not be as inclusive as we think. Like, for instance, hi guys, or when we talk about policemen or firemen. Now, not all of us are guys, right? So hi guys doesn't actually refer to everyone. And we have police officers and firefighters, maybe a better term, right? Just to make you aware. Okay, so EDI allows us to have conversations about inequality and injustice. I'd like to switch now and discuss some examples of EDI challenges internationally and what happens when we view One Health using an EDI lens. Now, one of the most recognizable and world-renowned conferences on One Health, except for this one, is the World One Health Congress. And this attracts global attention and global One Health experts. So this conference, unfortunately, has had noticeable EDI challenges. And a few of us from the region, we were present at the 2018 conference in Canada, where talks and panels were dominated by men, and mostly white men. We call those panels are called manels, right? So formal letters were sent to the organizers raising concerns about the lack of diversity and gender imbalance for speakers and moderators. Then 2022 happened in Singapore, and guess what? Similar concerns once again. So there is an upcoming conference in South Africa this year. And the organizers, they have acknowledged these issues and are working with groups to hopefully do better this time around. So let's wait and see. All right, let's move to Canada. I work in Canada with organizations whose mandates include anti-racism and EDI. One such organization is the Black Veterinary Association of Canada. It's called BVAC. One Health is currently dominated by the veterinary profession. In Canada, One Health is part of the curriculums at all vet schools, and it features in their public health institutions. The vet profession in Canada, it is not very diverse compared to Canada's overall diverse population. It is what we call a very vanilla profession. And historically, the leadership levels for veterinary medicine tend to be, in Canada, white and male dominated. So BIPOC, remember that term, Black, Indigenous, people of color, those vets are a very small minority. And within that BIPOC spectrum, less than 5% of Canadian vets are Black identifying. So that's a B there. And BVAC was established in 2020, and it aims to enhance EDI by inspiring and enabling Canada's Black youth to pursue careers in animal health. Okay, so let's move across to Southeast Asia. Now, there are extensive One Health networks and projects in Southeast Asia. Professor Latifa Hassan has been at the forefront of many of these efforts in Malaysia, and EDI challenges are also present there. And Latifa was kind enough to share some with us. So the first example Latifa shares looks at exclusion of local expertise from the start of projects. Latifa points out that One Health projects, they fail to engage local partners and experts from the outset. So projects are designed and planned without any local input, and local stakeholders are only brought in during the implementation phase. The second one that Professor Hassan has shared is the issue of unequal funding distribution in research grants. So research grants from developed countries allocate most of their funding to researchers from the respective donor country that are based in the recipient country. Latifa gives a lovely example of French grants given to French researchers based in Laos. Now, another challenge that Professor Hassan shares was the Western interpretation of local data. Western researchers analyze and interpret data collected by local One Health initiatives without involving local expertise. And this results in them controlling the narrative and interpreting local efforts, which undermines valuable local expertise and perspectives. Another really important point shared by Latifa was the issue of data collectors versus co-authors. As she explains that the role of local researchers gets reduced to data collection and permit acquisition. And when papers get published, local researchers receive minimum recognition, and they usually get an acknowledgement in academic publications rather than a co-authorship. All right, let's come home. So many of you know of the One Health, One Caribbean, One Love project. It was the first regional One Health project, and it was coordinated by the University of the West Indies. We had over 600 beneficiaries across 12 countries. And, to sum it up, guess what? We did it. We did it. We achieved a lot of success, and we won huge accolades, both regionally and internationally. This project exceeded its targets. It was delivered on time and on budget. We even wrote a book about it. However, that's only half the story. What really happened? So, for starters, One Health through the Caribbean eyes, we experienced a lot of what I like to call isms. There was racism, there was sexism, there was nepotism, there was neocolonialism. We had microaggressions, conflict, frustration, failure, and uncertainty. For example, our technical leads, they were extremely knowledgeable technical experts, but they had limited cultural competencies or tolerance for Caribbean norms and social customs. So beneficiaries experienced neocolonialism, and they were told that they were ungrateful for bringing up legitimate concerns. Experts from the US, Canada, and Europe were given preference over regional expertise, as regional experts were not educated in the global north, and they were not seen as equals. So gender stereotypes also prevailed, especially for Caribbean women of color. They were trivialized and undervalued. A Jamaican senior professor, for instance, was deliberately excluded from key activities because she was thought to be too Jamaican, which meant the stereotype here, she was too aggressive. And this is a great example of how these dynamics go unseen and unspoken. Now, using an EDI lens, we can bring these issues out of the shadows, and guess what? We can work with them. So another great example is who sits at Caribbean One Health leadership tables. Who makes those decisions? Who makes those decisions for One Health? And currently, a lot of funded One Health work is done by academia, and specifically by foreign academics and international agencies. And their focus tends to be on research papers and changes related to policy. So what's missing from here? Local voices, and those directly impacted by actions, including Caribbean One Health practitioners, NGOs, CBOs, and the people and communities they serve. And yet, they're the ones tasked to implement decisions they did not co-create and may not have necessarily agreed to. So who gets to tell stories about Caribbean One Health? Whose experiences, voices, and perspectives show up at conferences or lectures to speak on behalf of Caribbean One Health practitioners? Who gets invited to tell those stories? If your voice is not there, decisions are made without us. And the answer, it should be you. You are not a data point in someone's research paper. Okay, so what can we do? Well, we can become Jedi. We can become a Jedi in justice, equity, diversity, and inclusion. And how do we become Jedi? Well, here are a few steps. Step one, name it. There is language to describe these experiences. There are terms and concepts and ways to talk about it. It is hard to talk about this, but in my experience, it has become easier now to shine a light and to find allies. And this brings us to step two, act together. We are not alone. When we shine a light, it allows us to support each other. We are stronger, and this leads to the next step. Find and leverage allies. Step 3. Not only do we have each other in this region, there is space internationally. There are opportunities and networks, individuals and organizations who can support. And finally, step 4, be an ally. Sometimes we get pushed down and it feels as though we are fighting an uphill battle. However, it is always worth stopping and pausing for a moment to see if we are also pushing down on someone else. Are there ways we can uplift people? Do we have power? And with that power, can we also be allies? So my friends, it comes down to voice, inclusion, and power. By speaking together and by acting together, we can begin to change our circumstances for the better. Speaking of acting together, an example of us as empowered Caribbean people acting together for One Health is the recently formed Caribbean One Health Alliance. It is a professional network of Caribbean One Health practitioners supporting One Health in the region. We also have One Health leaders blazing trails. Of course, in Jamaica, we have Dr. Paul Cadogan and his team, as well as Delia Plunkett, who has continued doing advocacy. In Belize, there is Dr. Joe Myers, Dr. Julio Salvador, and Mr. John Bowden. We have in Guyana, Dr. Maxine Paris Aaron, Dr. Dane Hartley, and Dr. Renard Overton. And in St. Vincent and the Grenadines, Dr. Katian Herbert Hackshaw and Dr. Malika Glasgow. They and others continue to shine a light for the rest of us. So I wanted to share a quote from Professor Wanda Makota. She is the co-chair on the One Health high-level expert panel. It's called OLEP. She says, One Health is not a concept. One Health is a way of living. So I want to add here, if One Health is really about systems change, then One Health should be about social justice and achieving transformative change. And this aligns with OLEP. They refer to foundational principles that include equity and inclusion of marginalized voices. So have a look at this model. And you can see here by Peter Senge, he explains conditions for systems change. And when we do work around this area, we tend to focus on the higher levels of the triangle, on the structural change around policies and practices and resource flows. We are not as savvy working explicitly on relationships or connections, nor power dynamics, much less changing mental models, and this is where transformative change related to systems change actually occurs. We have to engage with the uncomfortable to make change in this world. One Health is about that change. Systemic racism, sexism, neocolonialism, and all the other isms are barriers we face in this One Health world. And these entrenched issues, they need to be brought to the forefront. We need to have conversations about them. We have to stand together, find allies, and also be allies. So EDI helps us to understand our mental models and also to break down silos. Jedi work is about transformative change. So in closing, I want to take this opportunity to do some reflections, personally and as a group. And this is not to answer now, but to take away with you, right? So personally, what does diversity and inclusion mean to you, professionally as well as personally? And all of you here are leaders. What does it mean to be an inclusive leader? Who do you include? And who gets excluded? Why? And are you an ally to a marginalized person or group? Now, as a region, who are our allies to Caribbean One Health practitioners? And who tells our stories internationally? Do they have our permission? Who controls the power and resources for Caribbean One Health? And who makes those decisions on behalf of us? So with that, my friends, I want to say thank you for your attention. And I am done. I have resources in case anybody wants, and I will be happy to share this.
All right. Thank you so much. Thank you. I'm seeing lots of comments in the chat as well. I see Fidelis Okali saying EDI must start at home. It's an interesting statement to make. Yes. And then everybody else is giving you very good presentation, excellent presentation, very informative. During the course of your presentation, I think a lot of people were especially excited by the image you had of what exists versus what is equality versus what is equity versus what is justice. And I appreciate, I think that's something that a lot of people don't know. I've seen that one before and I appreciated it. I even took a picture again, but it was excellent, excellent. So I'm going to check the Q&A and lots of emojis coming in, giving you lots of hand claps and love. I'm seeing no open questions. I'm checking, does anyone have a question?
That's okay. That's okay. I just wanted to say I am happy to do this, and I am happy also that we are. I know from this many people want to be Jedis, so I'm looking forward. Yes,
exactly. I'm about the Jedi life right now.
That's right. That's right. We are Jedis. Let us be Jedis in this.
Ally, I shall be.
Yes.
So thank you so much. And here's Fidelis Okali asking, how can we join?
Is it the Caribbean One Health Alliance or becoming a Jedi? Should we start a Jedi society? Which one, Fidelis? What are we thinking about here?
All right. So it says becoming a Jedi. There you go.
All right. Good, good. So here's what I'm going to share. These presentations will be shared with the participants. Is that right? So I invite you to take a look at the resources because, you know, this is an introduction. There is so much more. It's nuanced. There are layers to this. Take your time, go through the resources, and, you know, more than anything else, keep in touch with us. It is important work. This is happening now. This is real time.
Exactly.
So yes, keep in touch, and we are here for each other, right? Most importantly. Yes. I also want to say to the organizers, I was talking to my friends on the global scale. I think, and they would confirm this. This is the first EDI and One Health presentation that's being done globally.
Wow.
Yeah.
Wow.
So congratulations to the organizers.
This is applause in sign language. Wow, amazing.
I have to jump in here. I really have to jump in here. Adana, thank you so much for this. It's really a defining presentation. It really brought to the fore many issues that we may be seeing, and some of us may not be kind of, you know, seeing but not really grasping. So now we can be more aware and
exactly.
You know,
there's a bit of self-analysis that happens here.
Yes.
And just not only of your own personal self, but in your environment. What do you see in your workplace? What do you see? Become that Jedi. And I see a lot of people putting Jedi in the chat. Jedi. So, all right, Rabble Rosa, you've done it.
Yes.
You've done it.
Right.
Thank you so much.
Thank you.
Have a good afternoon. All right, I want to move forward. We are approximately half an hour behind, and I want to not get it any longer than that. So we're going to go forward now to some sponsor presentations. I believe we have a word from Healing with Horses. And I think, oh, Sean, hear me, Sam, I've lost my place again on my phone.
Your agenda. No, you're totally right. I believe we have Healing with Horses. So we'll welcome the representative from Healing with Horses to join now. Oh, it's Jackson.
Yes, and Sam, I got a message on my phone saying we're not taking any questions from YouTube. I don't have access to that.
That's totally fine. I don't think with the time that we have, we could anyway.
Okay.
Unfortunately.
Okay. So sorry
we'll
to those of you on YouTube, but definitely you can send them if anything, and we can try and get to some of them. But yes, Sam, so we have
so we were supposed to Yeah, we were supposed to have healing horses. Let me just get with Jackson and get him online. And in the meantime, we were also supposed to play the One Health Day song. So I'll play that now while Jackson gets back on.
All right. Thanks, Sam.
Earth, our home, a living, breathing planet. But we know things aren't always right. Climate change, disease emergence, overuse of our resources. We must change our ways and look to better days, but we need an answer to heal our ailing world. Yes, we need an answer. Man, woman, boy, and girl, we need to change, but we need an answer. The health of all is so interdependent. We'll rise or fall on choices that we make. Physicians, vets, and virocides too can't isolate the things we do. We must understand health rests in all our hands. One Health is the answer. We can do it if we try. One Health is the answer. Together you and I can heal the world. One Health is the answer. Again, when we come together and understand, united we prevail. For people, animals, and plants too, the land, the air, the water blue. Let this be our song, resounding on and on. One Health is the answer. We can do it if we try. One Health is the answer. And together you and I can heal the world. One Health is the answer. Yes, One Health is the answer. We can do it if we try. One Health is the answer. And together you and I can heal our world. One Health is the answer. It really is the answer.
Perfect. Now over to you, Jackson. Thanks very much.
Hey, good afternoon. Can everybody hear me now?
Yep, hearing you well.
I'm not technologically savvy. Share both my screen and the camera, so I have to say good afternoon. Head on.
Afternoon.
All right. Ah, Sam, I might be having some technical difficulty.
No problem. You need me to share it? Is it something you can send to me real quick and I share it?
Yeah, because it's telling me that Zoom wants to quit and reopen, and that looks a little risky.
Okay, yeah, just send it to me, email, WhatsApp, and we can take it from there.
Yes.
All right. In the meantime, I think we'll all right, just send it to me in WhatsApp, Jackson.
Okay. All right. 1 second.
Earth, our home, a living, breathing planet. But we know things aren't always right. Climate change, disease emergence, overuse of our resources. We must change our ways and look to better days, but we need an answer. Our ailing world, yes, we need an answer. Man, woman, boy, and girl, we need to change, but we need an answer. The health of all is so interdependent. We'll rise or fall on choices that we make. Physicians, vets, and virocides too can isolate the things we do. We must understand.
All right, so Jackson, I think we have the original presentation.
Yeah, that's what I was trying to tell you. Just use that one.
Okay.
All right, so very quickly, quick overview of what we're going to go through. So I'm just going to give you a little rundown about us, our vision and our mission, kind of our goals of what we're trying to do with Healing with Horses, a little introduction to our team who we have trying to push this program forward, and a bit of the session information, and just a couple of photos that we've taken. I couldn't post everything, so you can make way to the contact page and on social media to check out all the images. So pretty much I just wanted to give you a brief message. So I believe that if we listen closely enough, nature and horses in particular have the ability to teach us more about ourselves than we are aware of. We, like horses, are much more than what we can offer professionally. And my hope is that by providing this space and service, others may find the same peace and healing that I do. So this is ideally aimed at individuals, regardless of what age. So from your young straight up to adulthood that suffer from any type of disability or different illness, that anything under the sun, anxiety, whether it's mental or physical, it doesn't really matter. We're trying to provide a safe space that you're welcome to come and be at peace with nature and just have a glimpse at the tranquility that horses offer me. And pretty much I hope that you kind of find the same peace that I'm able to find with them. So our vision, what Healing with Horses is trying to do, is to promote animal welfare and a One Health mentality within the island. So that being said, the aim is to bridge the gap between humans and horses by providing a safe space where both may have the opportunity to safely interact with each other. What that means is that humans that have disabilities or that are suffering from different illnesses are able to come and find a safe space with horses that are also healing. So horses that may no longer have a racing career, or there was issues with, you know, their healing process or their growth process, you know, where they're not necessarily able to do a high performance job. We're giving them an alternative. So we're giving them an option to kind of earn their own keep. So it's an alternative to being put down and an alternative to just being out to pasture. So it gives them an opportunity to interact with humans and help the humans. And in turn, the interaction helps them heal. So right now, team is pretty much just me and the instructor. So we call her Auntie Debbie. So Auntie Debbie's been riding for, I put 30 years, but it's been longer than that. So Auntie Debbie is a certified instructor. She has been doing her own program, which is called Seeds of Change. So Auntie Debbie is primarily riding. And how I incorporate healing with horses is that, when we'll get to that a little later on for the session information, is that healing with horses is much more than a riding program. So it is a space where if you want to just have 5 minutes from work, you know, you've had a rough day, you work in Portmore, you're welcome to come across, you know, sit down, take a 5 minutes. You're welcome to interact with the horses along the fence line. You know, it's not a charge for that. Pretty much, we're just trying to create a safe space. So Auntie Debbie comes in with her riding program, in that if you do have different, I really don't like the word disability, sorry. If you're differently abled, then you're able to have, you know, physical therapy sessions. You're able to bring your therapist along with you. So if you have therapists that you've been working with, you come and you work along with Auntie Debbie. So Auntie Debbie is really there to ensure horse safety, right? So in terms of saddling up, you know, interacting with the horses, riding safely, whether it's walking, how fast we're going, helmets on, things like that. So Auntie Debbie is there for a safety issue and to ensure that you're really, you know, you're riding in the correct manner that you're supposed to be riding. I come in for most of the interactions. The picture that you see is a little snippet from someone's photo shoot that they just caught like a candid by chance. So I actually brought, I think she was taking her 1-year-old birthday pictures and she wanted to go in the pasture with the horses. So that is something that we offer. Yeah, you can actually go skip ahead. So the different sessions that we have now, so they're called Nose to Nose, Heart to Heart, and Call of the Wild. So they're based on the level of interaction that you're getting. So it starts off as simple as nose to nose. So these are the ones where it's like a guided interaction where you have to make an appointment, right? You don't necessarily have to make an appointment to show up to hold a 5 minutes. Sorry, there's a concrete table there. There's trees, you know, you're welcome to come park and sit. That's not, there's no charge for that. The guided interactions are, so nose to nose, we're kind of just at the stall door. So that's really for people that, you know, they've never been around horses before. It's really an introduction. So, you know, it's a getting to know you thing. So we go over safety and, you know, they can pet, things like that. And you get about 30 minutes, educational, ask any questions you want, pictures, things like that. Next step up is heart to heart. So it's just a little bit longer, well, 30 minutes longer. And you're able to go in the pasture, in the stall. You can use the hour however you want to use it, pretty much. And you can groom if you want. I say grooming is optional because I would advise, like, if you have a lot of allergies, that sometimes the grooming, we don't necessarily want to do that. You might have a reaction to the horsehair. So if it's your first time being around horses and you're not quite sure, grooming is very optional. So we start off, I'd suggest maybe start off with nose to nose, and then Call of the Wild is our riding session. So you're allotted 45 minutes on horse, and grooming and saddling time is complimentary. So it doesn't really matter how long you take, but typically people are usually saddled up within 15-20 minutes because they're really excited to ride anyway. So those are the different sessions that we have, and you're welcome to call or email. Yep, time, got it. Yep, so these are some pictures. So here you go. I'm trying to move it up. So pretty much it doesn't matter what age, right? And we work really closely with the Racing Commission right now. So injured horses, rescues, we welcome them with open arms, and we provide stalls, and we do rehabilitation for them. So there you go. If you have any questions, you can email, call, and check out the social media page. Thanks very much for accommodating me. I really appreciate it.
Thank you, Dr. Hefes. Thank you so much. And I hope that you will put your contact information again in the chat so that there are a few questions coming for you. So you can go ahead and put your contact information in the chat, and any of the participants can feel free to call you or contact you. I don't know if Sam can just display that last slide one more time with the info. Anybody who is on YouTube or on our Zoom meeting now, if you can make it a little bigger, they can go ahead and take a photo real quick with your phone. Grab your phone, take a photo. And those of you who are here can get the info in the chat later on. All right, I'm giving you 10 more seconds. 9, 8, 7, 6, 5, 4, 3, 2, and you got it. All right. So I'm just watching the clock, guys, because I know it's been, yesterday I was here all night with you guys as well. So I want to make sure that we stick as close as we possibly can to our end time. So we are still about half an hour behind, about maybe 35 minutes now. So I want to just go ahead and quickly introduce our next speaker, who is Joseph Joey Brown, the general creator of Hope Zoo, managing a collection of over 1,400, wow, I got ahead of myself, 1,400 animals, along with the Conservation Head Start program for the critically endangered Jamaican iguana. He is one of the founding board members for the Animal Assisted Recovery Care program, which recently launched the first animal therapy initiative in Jamaica. Prior to Jamaica, he completed his Master of Science degree at the University of Oklahoma, his Bachelor of Science at the University of Kansas, and spent 5 years working in the herpetology department at the San Diego Zoo in California, USA. So if you hear an accent, you know,
of course,
we're not going to be surprised, but he has been living here for a long time. So we hope a little yard is slipping every now and again.
We'll see.
For his master's degree, Joey studied as a Fulbright research scholar and National Geographic explorer, researching the ecology and conservation of the critically endangered Philippine crocodile in the Philippines and the critically endangered Fijian crested iguana in Fiji. Specifically, his research focused mainly on the spatial ecology, diet, and use of Head Start programs as a conservation tool for threatened species. Please put your emojis up for Mr. Joseph Joey Brown.
Thank you, Dr. Leon. All right, let's see. Do the screen share. Can you hear me okay?
Can. Yeah, we can.
All right, try to get this going. Come on. Right. It's showing up. Wait, what's going on? Sorry. Share. No. Oops, wrong one. One sec. Having some difficulties. This one. All right, it should be up now, right?
Yes.
Okay, great. So yeah, thank you, Dr. Leon, and thank you, Dr. Cadogan. I appreciate you giving us a chance to talk about our new animal therapy program in Jamaica, specifically titled The Pet Effect and the Animal Assisted Recovery and Care Program at Bustamante Children's Hospital. We'll jump right into this. So just a kind of overview of what I'll talk about over the next 20 minutes. I'm going to kind of give a brief history on the human-animal bond and how therapeutic benefits were first kind of observed. Then we'll kind of jump in like the pet effect and specific kind of research and animal-assisted therapy benefits. And then we'll end with kind of the exciting of a recent launch of our animal therapy program here in Jamaica. So the pet effect is kind of just a more modern term for the human-animal bond. Humans and animals have been interacting for over 50,000 years, but it was more recently when domestication took place. So obviously in dogs, our canine friends, this began about 15,000 years ago. Cats, 9,000 years ago, and domestication of horses around 6,000 years ago. The dog meme, as funny as it is fairly accurate too. So I mean, the wolves literally, first came into contact with humans was coming around human encampments, kind of as scavengers to pick up food scraps. And then slowly over time, they became more comfortable around people, and then they kind of developed roles in security and even hunting. And then 15,000 years later, human selection, we have, hundreds of different, countless dog breeds now. Similar situation for cats and as well as horses. Horses first came in touch with humans and were used as transport, used in the military. And they also serve as some amazing therapeutic benefits. And I will note this presentation, is mainly focused on kind of dogs and pets. And I don't really have the time to touch on horses. I'm glad Jackson spoke a little bit ago and got to give a brief introduction on the amazing kind of therapeutic and benefits of working with horses, as I won't have too much time in this discussion. So, kind of going from 15,000 years ago to the recent 1800s is kind of when therapeutic benefits were first. Remove this. Sorry, my screen just messed up. The therapeutic benefits of animals were first kind of noticed in science, but not necessarily documented. So Florence Nightingale, who's really literally the founder of modern nursing, was writing her book, Notes on Nursing, when she noted kind of small pet animals would help patients recover by reducing anxiety for children and adults in these psychiatric institutions. This is already in the mid 1860s or so. It was also in the late 1867 when pets were starting to be used as a treatment center for epileptics in Germany. But even at this time, this was just kind of observations and hadn't been documented as of yet. It was until 1961 when Dr. Boris Levinson, the psychologist, actually did a presentation and a publication in the Journal of Mental Health, kind of where he had documented by chance the positive effects of a dog with this disturbed, non-communicative child in a psychotherapy sessions. Dr. Levinson actually was working with this child who was non-communicating, having issues, and by chance with his dog Jingles happened to be in the room. Over time noticed that the patient was actually becoming more comfortable and relaxed and that his communication skills were increasing whenever the dog was around. And this is when he started expanding it to other child patients and even elderly. Dr. Levinson is actually the one who coined the term pet therapy, which we now kind of has more been translated to animal-assisted therapy. The funny thing is, though, in the early 60s, Dr. Levinson gave a presentation on his research, and he pretty much got laughed at by a lot of the colleagues in this field. This is a brand new thing. No one didn't believe this was possible. And, he kind of almost got shunned in a way. And then coincidentally, a few years later, Dr. Sigmund Freud, he'd actually died about 20 years, but 20 years after Dr. Sigmund Freud died, they were translating all his notes. And while they were publishing a book, they had found numerous notes on Sigmund Freud kind of advocating for pets as therapy dogs, as he noted they would kind of facilitate kind of communication, and he made his patients more comfortable. He was also working with psychiatric kids and elderly in the hospitals, and he noticed he had a chow chow named Joffe, that he noticed whenever Joffe was in the room, he was getting better results, more relaxed kind of energy with his patients. And so it was actually when Dr. Sigmund Freud, with his reputation, that the industry kind of became more supportive and research really started to take place. Kind of before we jump into more of the modern research and stuff going on, I just wanted to clarify some of the different categories. Obviously we have pets, our pet dogs, cats, birds, horses and everything. And then you have our animal-assisted therapy animals, emotional support animals, and then you have your service and working dogs. There's a very big distinction, especially between the service working dogs and the animal-assisted therapy animals. Service and working dogs require extensive training and certification. These are dogs that help with CNI people. They are medical alert dogs, possibly helping with epileptic people. Alert of seizures. They have very good healing powers for PTSD, and then they replace the military dogs. Training for these dogs can take easily over 1.5 years, 2 years, costs $10,000 to $20,000 US, and is a very much more extensive. Oops, that's supposed to happen. Much more extensive training, and then these dogs also have full access to anywhere. At least talking in the US, going in anywhere that people can go. Whereas, kind of what we're talking about today, more pets and animal-assisted therapy or ESAs. These dogs, they receive at least very basic obedient training, socialization. They do require yearly health and behavioral certifications from a vet. And also for ESAs, which are emotional support animals, they require almost a certificate or prescription from an actual physician. And they don't have the full access like service dogs do. So they do get access to schools and hospitals and help with housing. But the training is definitely much more, there's a big difference between the AAT animals and the service dogs. And just some quick terminology, because it may be during the verbiage, you'll see a couple different terms used. Animal-assisted therapy is the same thing as animal-assisted intervention, and the same as companion animal visits or even pet therapy. All these terms are synonymous with each other, and they try to change over time, and some groups use different terms. All right, so the pet effect and animal-assisted therapy, kind of what's the goal? So clearly, dogs, cats, these pets clearly improve mood and have an amazing calming effect on animals. That's why we have them as pets. You love to come home from work. They make you happy. You love taking care of them. And so, but with the AT, we wanted to find the more clinical benefits of kind of proving that they do help improve, promote improvement in human physical, social, emotional, and cognitive functioning. This is now a globally recognized kind of service, especially more in the US, Europe, and it's slowly spreading other places as well. And the benefits are, now up in 2023 are becoming well known for not only just pet owners, patients, and even healthcare providers are now thankfully realizing these amazing benefits. All right, so I kind of go over some of the more clinical benefits and how, pets and AT can augment health and well-being for not only just pet owners, but for hospital patients. So I'll quickly touch on a few of these and then we'll jump into some more clinical cases. So a growing body of research shows that pets and AT help with lowering stress and anxiety levels by decreasing cortisol, lower blood pressure, triglycerides, lower risk of heart disease. Children exposed to pets at an early age are also shown to develop fewer allergies, strengthening their immune systems, and increased social interactions, decreased loneliness. Pets in general, but even AT therapy programs have been shown to be especially useful for children and the elderly. Elderly that are possibly living in nursing homes, who are suffering from loneliness, suffering from dementia. Dogs have been shown to increase socialization. Dogs and cats should increase socialization, provide kind of that companionship and just improve overall mood. And the same goes for kids that are possibly in hospitals for long-term or in schools. Good. So some specific, let's jump into kind of some recent research for cardiovascular benefits. So a 1995 study in the American Journal of Cardiology studying nearly 400 patients who had a heart attack those who own dogs had a significant increased survival rate at a 1-year follow-up. And the mortality rate was over 4 times greater for those who did not own a dog. So in the US alone, 83 million adults suffer from cardiovascular disease, and it's one of the leading causes of premature death. In 2013, the American Heart Association released a scientific statement regarding pet ownership and CVD risk. Through a critical assessment of data regarding the influence of pet ownership on the presence and reduction of CVD risk factors, the AHA, American Heart Association, concluded that pet ownership, particularly dogs, is likely associated with a decreased risk in these CVD risk factors. Some more cardiovascular, not just dogs. Can't forget about our cat friends. I have limited time. I'm sorry, but published in the Journal of Vascular Interventional Neurology, and this is like nearly a decade-long study. Over 4,000 Americans surveyed. The simple act of owning a cat is not only calming, but it can lower your blood pressure and boost your overall health. And it led to a 30% reduction in the risk of fatal heart attacks. This is pretty amazing that just having a pet cat, can just show how it can improve your quality of life. I'm not sure if you guys are familiar, you watch TV and you see those ridiculous prescription drug commercials that come on. They promote this big positive thing that their drug could do, and at the end it has all these ridiculous side effects. I found a pretty funny video that talks about this company that kind of promotes animal therapy and the benefits. They did a similar commercial for the prescription of a cat. So I'm going to go ahead. It's just a minute long, so I'll pop this on real quick. All right. So yeah, just let's see. No. All right. I just had to throw that in there. I thought it was pretty hilarious and to kind of lighten the mood for a presentation. But it's actually a very good, education outreach technique to kind of prove these amazing benefits our animals can provide. So let's look at some more research on cognitive benefits. Like I mentioned earlier, the elderly are a very kind of beneficial group that is really kind of gets amazing gifts from these animals, especially when it comes to elderly with dementia, behavioral and psychological symptoms of dementia. In 2013, a study in nursing home residents showed that the presence of dogs, whether it was a resident dog or the trips from AAT dogs, would actually delay these symptoms, delay the progression of these symptoms. Agitation, aggression, depression, which usually progress pretty extremely with dementia and Alzheimer's. It was actually a randomized control trial that investigated the efficacy of AAT on these symptoms, and they found that this intervention would actually delay this progression. Residents were randomly selected and assigned, either they were assigned their normal treatment or their normal treatment plus this combined with the AAT dog or visits from the AAT, routine visits with an AAT animal. Residents in the control group, which just received their normal treatment, experienced significant increase in their symptoms of agitation, aggression, depression, whereas symptoms of the group that had the treatment plus the animals, their symptoms remain constant. So there was no progression. And this is a neat study that kind of showed that, they can possibly delay and help kind of make this disorder less extreme. So let's get back kind of where it all started. Obviously I started off talking about this presentation in the early 1800s where psychological benefits were some of the first kind of noted observations. And this is even more prevalent today. Dogs, animals, cats, horses, obviously promote very positive emotions, improving our overall mood, improving social and communication skills, decreasing anxiety. There's some more, there's numerous studies. These are just some neat ones I picked out. on a 2006 study at nursing home where dog ownership or dog companionship was offered 3 times weekly for 90 weeks. This was published in the Journal of Psychosocial Nursing and Mental Health Services. During such kind of encounters, the dog became a source of encouragement by being non-judgmental and attentive to the patient. So these pets are often this loving kind of non-judgmental partner. The pet would stand next to the wheelchair, the bedside, they make eye contact, they develop this kind of bond with the patient, and this fostered a very nice healing environment. And in the end, they showed a clear reduction in loneliness, depression, and social isolation. So hospitalizations, these are, whether you're going for your sick or injury or trauma, something, these are often very traumatic experiences. And the stress of being admitted can further compound whether illness or condition has brought you to the hospital. Clearly, AT is another treatment that can help alleviate these psychological stresses. And it's been used in acute settings to help counterbalance these psychological stressors that may increase blood pressure and heighten anxiety. If we can counterbalance that pressure, those factors, the faster we're going to improve the healing time. So this 2007 study published in the American Journal of Critical Care evaluated the impact of a 12-minute hospital visit with a therapy dog on hemodynamic measures, neurohormone levels, and anxiety in adults with advanced heart failure. This ended up showing a reduction in both mental and physical effects of the excited sympathetic nervous system. And the results, this was demonstrated by improved cardiopulmonary pressures, decreased epinephrine and norepinephrine levels. So this is just from a few routine visits of a dog with 12 minutes with these patients, and you're getting these outstanding results, which are possibly shortening their hospital stay, reducing their costs, improving their quality of life, and also on the other end, reducing healthcare costs all around. All right, this wasn't really included in my presentation, but when I was kind of reading around, I found the story, so I just wanted to include it because I was really impressed, and really, as we're talking about the human-animal bond, I thought it'd be cool to kind of mention it. So Oscar was this cat that this retirement home rescued, adopted it to be like their almost kind of little resident therapy cat at this nursing home. But when they adopted him, they were kind of upset at first because he really showed no interest in socializing or being with any of the patients or being with any of the elderly people at the home. That was until they finally started to notice that he was cuddling up to certain patients. Well, they actually found out or noticed after over 10 or 20 times that the cat would actually, he used to like hide out in a closet or hide out in certain rooms, but he would come out and he'd go to specific people's patients, to their bedrooms, and honestly just curl up next to them in bed. And they noticed that he was doing this specifically for patients that would die within the next few hours. They kind of said he would predict the death. And they keep doing that. Let me go back. Okay. So, I mean, they're absolutely blown away by this, and it actually proved a very beneficial one. Obviously, he was curling up next to these patients to comfort them in the final hours. But in the end, this gave kind of the hospital care staff some time, because once they learned this, as soon as they saw Oscar curling up to the patients, it gave them time to notify the family members so they could get there in time and possibly say goodbye before unfortunately, their family member would pass away. Over 17 years, Oscar ended up doing this with pinpoint accuracy to nearly over 100 different patients. The hospital care staff, even one time, they had someone that they thought was dying, and so they were literally trying to put Oscar on the bed with him, and he refused to go on him, and ended up running back to his room. And then the patient ended up surviving for a few more days, and then what do you know? A few more days later, Oscar willingly came into the room and curled up next to that exact same patient. And so I thought I was pretty blown away and pretty impressed that just shows how the capabilities of humans and animals. And the researchers speculated Oscar could actually smell biochemicals released by dying cells. And so he kind of literally just chose to comfort them kind of in these final few hours. All right, so now we're going to transition to here in Jamaica with our Animal Assisted Recovery and Care Program, or we'll say our ARC program at the Bustamante Hospital for Children here in Kingston, Jamaica. I'm excited to share this with you guys. We have an amazing team, and this is a really exciting initiative we have just started going on. So first, let's meet our team. it's combined. We kind of had this, I like to call our dream team of just everyone amazing that kind of we came together to make this possible. It started with Minister Chris Tufton at the Ministry of Health and Wellness. We have Dr. Marcia James at the Bustamante Hospital for Children. Obviously, very other hospital staff as well. Dr. Stinnett, Dr. Watson at the Ministry of Agriculture Veterinary Service Department. Amazing staff at Hope Zoo. Pam Lawson, her amazing staff at the JSPCA, and then Tammy and all our colleagues at the Montego Bay Animal Haven. This is really, I don't think this program, what we've seen a bit, would not have been possible without kind of this collaborative, amazing effort that kind of took place nearly almost 2 years ago. So, although we recently just launched this program, it was April last year, there was a whole lot of planning and stuff that kind of went into it beforehand. We initially came up with this idea, and Tufton kind of brought us all together. It was in January 2022, so nearly a year and a half before the actual launch, to kind of get everything in place. We wanted to make sure this is obviously, animal therapy is obviously, we've talked about, is globally recognized, and all over the US. It's in hundreds of hospitals and treatment centers throughout the world, but this is obviously a brand new thing for Jamaica. And moreover that, dogs, don't really have much protection or, let alone service animal policies here in Jamaica. So this is really a brand new initiative. So, that's why we had to bring everyone from animal care to veterinary to human care from all around, the island, all these professions to bring them together to take place. So we literally, January 2022, we had our first board meeting, and from then on out, we literally had weekly meetings, usually weekly Zoom meetings over the next year, kind of getting everything in place. Starting with what are our objectives and goals of this? Making sure we had every safety protocol, policies in place. We had to be looking at zoonotic disease risk, looking at allergies, having all different risk factors kind of planned for and reduced. We reviewed current AAT policies, throughout the United States. What are the most modern kind of policies and techniques being used? We had obviously our animal aware policy. You're in these programs, you're focused on obviously the hospital patients and the people, but our also main focus is the animals. We want the animals to be happy. We need the animals to be healthy. We can't be putting these animals in stressful situations. So that was obviously very important. We had to come up with a visitation protocol and kind of standards. And then finally, we need to be able to evaluate this project. We need to collect data along the way. So obviously we can have our own publication and publish this stuff. And, we want to be able to say, yes, it's doing this, or what are these positive benefits? And this will even further help kind of this program grow and help prove to, the world, but also even Jamaica in general, how beneficial these animals can be, starting off just at Bustamante Hospital, but eventually hopefully growing to numerous other hospitals, elderly homes, and schools. So I guess first starting off is like, what animals are we going to use? So obviously dogs were the number one thing. Dogs are kind of like the poster child for most animal therapy programs. We had Dr. Tufton had the idea of coming up with a specific, our own dog who would be kind of the poster child for our ARC program. So that came out to be Teddy, or Dr. Teddy Barks, who's the golden retriever sitting there in the wheelchair. We got him as a puppy at 8 weeks. He began living at home with me and undergoing various training to be ready for this program several months later. We do have plans. We have other dogs that we use as well. I have another dog named Kuya. Montego Bay Animal Haven has a couple other dogs and Phoebe, the Palm, that we use. But Teddy was kind of gonna be our poster child, since it was such a new thing for Jamaica. And golden retrievers are one of the more common breeds that are used in hospitals. Although various breeds are used, it's more depending on temperament and the socialization of the dog. But with this being a new thing for Jamaica, we want to use Teddy, the golden retriever, who's been an absolute amazing addition to the team, and who's now almost like a celebrity wherever we go. So other animals, we are going to also introduce kittens, rabbits, snakes, and turtles. So I remember we were like in our first or second board meeting, it was pretty much, we were like, oh, we're going to do dogs and cats. I was like, well, no, we're talking about using additional animals as well, and with me working at the zoo and having an amazing team here, and we do a lot of outreach with some of our ambassador animals. Obviously people love the furry stuff, the dogs and the cats and the rabbits, but you'd be honestly surprised how the snakes are one of the biggest hits when it comes, especially with kids. And there was a lot of pushback at first when we proposed using the snake, but I was like, just trust us, we're going to try this with our pilot project. And people are honestly blown away. Once we did our pilot program and we did some practice sessions, people go running for the dog, but then the snake is usually the first or second one they go running for. And you have kids who are lighting up with joy, just having this relaxed snake, whether around their neck or holding them. And so that was a really neat thing to see. And the same goes for the turtles and the rabbits, but it was neat to see the kind of that benefit or that kind of the excitement and stuff from the snake. And then also the surprise on the doctors and the hospital staff as well. So before we jumped right to the hospital, we obviously want to do some practice sessions at various schools around Kingston. We wanted to have this kind of start this off right, once we got into the hospital setting. And so we started, going to although we'd done it at the zoo, we wanted to start going to various schools. So we had, dogs we were using and meeting with various school groups. And this helped a lot because it helped us kind of bring a more controlled manner to the therapy sessions. Because, that was our goal, is to have things very kind of standardized, controlled. When you get a bunch of kids together and you get a bunch of animals together, it can turn into a very exciting thing. So for the hospital, that helped us realize, all right, we're going to have certain stations. This is going to be the dog station where there's 2 handlers, a hand sanitizer, and 2 kids allowed at a time. And then over here, we'll have the snake station, similar replication of staff. And then over here, we'll have, the cat station. And, when only a number of kids and patients were allowed in at a time. And so I'm going to just show a quick video and that kind of talks about how this started off. So, we talked about our planning process that went on behind the scenes, but there's a whole lot of work that went in by Minister Tufting and getting this pushed forward in the government. This is obviously a brand new thing for Jamaica, and it took a lot of push to get this, through support and funding from the government, and kind of get this moving ahead. So I'll start.
Not getting the audio, unfortunately.
No?
Oh,
No audio?
I think it's how it's shared. I think you have to share with sound. You should see it in more, where it should say share sound as well.
Under more. Oh. There's sound. Oh, share computer sound. Here we go. What's going on?
So we should hear it now.
Asking for a pass.
Password. That sounds like a Mac.
In Jamaica,
hear it?
Madam Speaker, there has never been
yes.
an animal assisted recovery program. So this is a first for us in this country. Hence the pilot project. Several animals will be used in the project, Madam Speaker. But today, I would like to introduce our brand ambassador for the animal assisted program, Dr. Teddy Barks, or Teddy for short. And Madam Speaker, he's right up there. Madam Speaker, the Health Ministry utilizes pharmacotherapy to alleviate patients' anxiety and other psychological symptoms. However, these interventions do not always effectively manage patients' total care. Evidence in other jurisdictions outline that animal-assisted recovery and care programs can be utilized to complement these interventions. So we start the work now here.
All right.
In Jamaica, Madam Speaker, there has never been.
All right. Cool. So yeah, this is a really neat and exciting day. You know, Teddy was officially the first dog to go in Parliament. The day before, we went to the Prime Minister's office, and it was a really exciting several days. And you know, especially with dogs, animals in general, lacking any sort of protection and very outdated policies here in Jamaica. I think this was an amazing big step for the therapy program, for a good kind of starting step, hopefully, to get more protection and rights for our animals and pets here in Jamaica. So next one. All right, so just to finish off, talk about a few of the results. You know, this is not this program is initially an 18-month program. We're about 8 months into it. So we just have some ongoing results we've seen so far. So obviously just general improved mood in a lot of the patients that come, day to day. And the doctors and nurses have observed and told us about improved kind of social activities and communication, both obviously during and between sessions, and just a more relaxed overall feeling with the kids. They do like, I'm trying to say, it's funny to see how like we started from day one, because we get new patients here, but there's several patients that have been there since the beginning of this program. And from the first time we started with the first session, when they were very reluctant to maybe come up and pet a dog, or to let alone pet a snake, to our sessions now, 6 8 months later, where they literally are kind of almost running down the hallway excited. And at the end of the session, they're almost like, "Oh, you're not leaving? When are you coming back next?" And you see that excitement and that kind of enthusiasm. And so it's really neat to see that already in just these kind of early stages. And I will note, these exact same results are being seen for the staff. This whole program was designed for these kids, for the patients. And, we didn't even think about you don't necessarily think about the staff, but you have these doctors and nurses that are working crazy stressful hours, all day long, and taking on very serious cases. And honestly, like when we have these therapy sessions, they're coming to these sessions right away, and it's great to see them kind of cut back, relax. They even tell us that, "Man, this is the first time I've relaxed. This is the first time I felt relaxed, in 20 hours, and you see these smiles and happy kind of laughter on all the staff. And so I think it was almost like a bonus benefit, or an additional benefit, obviously, is the patients plus the staff are receiving kind of mutualistic kind of rewards in this program. And then some kind of additional impacts that are more relevant even here for Jamaica. Dogs, unfortunately, other animals are often seen as maybe nuisance, street animals, and don't necessarily have the care and affection as some other places. And we're definitely seeing with both patients and their parents kind of increased empathy for these pets, and even the snakes and turtles. And oftentimes I'm working with the kids, and they're sitting there petting Teddy, and they're like, "Oh man, I can't wait to get my own pet dog." And just hearing that over and over again from various young Jamaican youth is very awesome to hear, because that's what we kind of want to share, is our love for these animals. So then as these kids grow up, we're going to have more of a kind of love and compassion for these animals throughout Jamaica. So just like to give some quick acknowledgements and a huge thank you to the ARC Dream Team, everyone at Montego Bay Animal Haven, JSPCA, the Ministry of Agriculture, our Vet Service Department, of course, Minister Tufton, all the amazing staff and patients at Bustamante. And I can't thank Dr. Paul Cadogan enough for giving us a platform to talk about this, and just kind of over the last several months having some nice talks with me and sharing some very good information on different research he's done on service animals and stuff along the way. So thank you very much.
Thank you. Lots of love coming to you, Joey. Lots of love coming for this presentation. Lots of comments. I tell you, a lot of people have put in, "Yes, man, dog. I want to have a dog." A lot of people chatting. I seen, unfortunately, not so much love for the snake. One person just wrote, "I'll have a dog, never the snake."
I know we get that, we get that, and we don't. I'm not forcing anyone to love a snake. I'm just saying you'd be surprised at the number of people that end up loving this thing.
And see, Sherry Taylor saying she going to get the dog tomorrow. Sherry Taylor, make sure you understand dogs come with a budget.
It's true. It's true. That is true.
So remember, there's a budget involved with the dog. It's not just the dog. You have to feed it and you have to pay money to care for it.
Yeah, that comes in.
And someone is asking if possible for you to play the cat commercial again because you didn't have the sound on at that time.
Oh, really?
You never heard it.
Oh, you guys didn't hear that? Okay.
So
let me go back real quick. It's only a minute.
And while you do that, I will just say, there's some people here talking about cats as well. There's loving that there's stats on cats. I will tell you, I will confess to everybody here, I used to hate cats when I was younger. And now I have a cat and I don't know what I would have done without this cat. This cat is amazing. So
I can't believe you guys just watched that whole video with no sound. No, I agree. I can try to pop it on real quick. Let me see.
And and another person, someone else said, just watching Teddy on screen was therapy. So I just thought, wow,
Yeah.
that's amazing.
All right, so let me try this real quick.
Here's our cat video, everyone.
All right, make sure the shared sound is still on. All right, here we go.
I found a way to relieve my
You hear it?
depression.
I found a way to lower my cholesterol.
I found a way to strengthen my immune system.
I found better health with Cat.
In clinical studies, prescription-strength CAT has been shown to be effective in strengthening your immune system, preventing allergies in children, lowering cholesterol and triglyceride levels, reducing stress, and decreasing anxiety and depression. Side effects may include difficulty breathing because a cat is sleeping on your face, trouble working because a cat is on your computer, issues packing because a cat is in your suitcase. You may experience trouble peeing because your cat is staring at you. You may spend all day posting pictures of your cat on social media. Some cat owners experience nausea at the sight of dead rodents on the doorstep. Things may fall from tall surfaces and break because your cat knocked it off and doesn't give a kitty litter. You may feel a strange sensation that you don't own your cat and that your cat actually owns you. Discover better health. Ask your...
All right. I didn't finally work that time. I can't believe you guys didn't hear it the first time.
Difficulty breathing because the cat is sleeping on your face. Listen, I live that one. Oh, I love it. And I'm gonna say this one. Mary Mitchell, thank you for the excellent presentation from this handsome individual. Hello, Mary, behave yourself. All right, thank you so much, Joy. Are there any questions, other questions in the audience? Because I'm not seeing any questions per se, because everybody's eyes have been opened. People are just loving that this is something that is instituted in Jamaica. They're happy to see the support, and I'm happy to see that you are getting the support. Amazing presentation. I mean, I've seen it before, but every time I see it, it's even better. So thank you.
Thank you. I appreciate you letting me talk.
One question I see in the Q&A. How old is Teddy?
So Teddy will be he'll be 2 years old coming up in April.
Nice.
So we got him at the very beginning of the program. We got him specifically, at 8 weeks old, and he's been with me ever since.
Oh, I did see a question as well about how easy is it, or is there a program here now where people who have pets that may qualify to be therapy dogs? Are there any programs now where we're training local dogs to be therapy dogs?
There's not currently in Jamaica, but the goal for this program is, after kind of more towards the end, after the 18 months, is we will start kind of expanding to possibly having other people bring their dogs in, and then we can do kind of almost our own certification and verify that they would be suitable animals for the program. So I'd say just give it a little bit more time, and then once this program ends its time and kind of comes in, we'll expand with more other people's animals and volunteers. This is how it is in the U.S. too. I was reading one at Johns Hopkins University. It started like 8 years ago. They started with 1-2 dogs the first kind of 2 years, and now 7 years later, they have nearly 20 dogs, with these volunteer handlers who are just normal people, normal, typical citizens who have kind of dogs that fit well for this kind of work, and they volunteer their time. They volunteer their time to come into the hospitals, and it's the dogs love it, the patients love it, the handlers love it. Everyone gets a really neat kind of reward out of it.
Yeah. I mean, I've seen on YouTube even a guy in the States who has what he considers to be a therapy crocodile. I don't know if you've seen that guy.
Yeah.
Very interesting stuff. But as I again just want to thank you so much for yes, therapy crocodile. Thank you so much for this presentation, and I again just appreciate you. Have a good evening.
Thank you so much.
All right, so we have one more presentation tonight, everyone. Look at Joey. And look at that macaw. So
Teddy and Bubbles.
So we have one more presentation tonight. Someone asked for the link to the cat video, so if that can be posted in the chat, they would appreciate it. So if that wasn't therapy enough and make you feel good after this, long evening, we have Dr. Aldith Buckland coming next to make you feel even better. She is a graduate of the University of the West Indies, Mona, accredited member of both the Caribbean College of Family Physicians and the International Board of Coaches and Practitioners. She's an accomplished and experienced family doctor in her own private practice, empowering herself, her patients, and their families to take charge of their life and health through participatory integrative practices. She has mentored UWI medical students in general practice specialty. She's a 2025 Star Doctor Awardee of the Caribbean College of Family Physicians. She serves as a member of the WONCA Working Party on Mental Health, is a past president of the Ccfpj-Jvma, vice president of the Association of General Practitioners of Jamaica, member of the Medical Association of Jamaica, and is its insurance committee chair. An honorary member and volunteer of the Jamaica Cancer Society, serving in smoking cessation training and guiding the public in lifestyle interventions. She is certified in Caribbean Climate and Health Responder course by the Global Consortium of Climate and Health Education, Columbia Mailman School of Public Health, Earth Medic, Earth Nurse. She represents the CCFP on the Caribbean Regional Hub of Planetary Health Alliance, and along with Dr. Paul Cadogan, Dr. Aldith Buckland serves as co-chair of the One Health Conference, a collaborative venture between the JVMA, the Jamaica Veterinary Medical Association, and the Caribbean College of Family Physicians, the Jamaica chapter. She has 2 grown-up daughters, a loving family, wonderful friends and colleagues, enjoys nature, walks, practices yoga, qigong and meditation, listens to music, plays with her dogs, yay dogs, and serves the Almighty who makes everything possible. Please welcome Dr. Aldith Buckland. Emojis, emojis, emojis. We need to switch from Joey Brown to Dr. Buckland, Sam, on the screen. Dr. Buckland, we're excited to have you. We are super excited. We know that we're going to have
Thank you.
A wonderful time. I mean, we had a beautiful therapy dog session just now. Just watching those videos was therapy. And now we know you with the mental health aspect, it's already peaking, and you're just going to carry it all the way up. So looking forward to that.
Okay, great. Let me get, everybody can see the screen?
Yes, we can.
Wonderful. Good evening, everyone. Mayday, Mayday. Coping with life stresses as a health professional. One day, this evening, I would like to know in my Mayday if you can see me. Can you all see me or just the screen?
I'm just seeing your screen.
Oh.
It's the screen.
Okay.
Let me see. Do you see a request to start your video?
It's all right.
Okay.
I will have to do the demonstration after. All right, Mayday. Mayday, I believe, also can be spelled apostrophe AIDER, which is to help me in French. So it's very important as health professionals that we recognize that we're human and that we have a program running us. We can either run the program or the program can run us. So it's very important that we check our patterns and triggers so that we can create programs that will work for us. Now, the programs, how this all happens is because when we are, as humans, we are going to use our senses. So what we see, what we hear, what we feel, what we taste, and what we smell will come in, and it's all processed in the brain. So it will delete, distort, or generalize certain information. And then all of this is internally represented as something into the brain. There's no meaning attached to it. It's just internally represented. And then all of this is now filtered through other processes, time, location, or mood, metaprograms, language, memories, decisions, beliefs, values, and identity. And as a result of all of this, then it can actually affect how it will affect our state, it will affect our physiology, it will affect our behavior and our results. Now, one of the programs after the delete, distort, generalize part is one of the programs called Toward and Away. So you remember during COVID, some things are familiar, so you go toward that. You don't like something, so it's unfamiliar, so you're away. If something is familiar or pleasurable or friendly, you're going toward that. If it's unfamiliar, there's no pleasure in something and it's unfriendly, you're staying away from that. So these create our thoughts, but it doesn't mean that our thoughts are the truth. So we got to question our thoughts. So question our thoughts. So when did I decide that? Anytime you have a thought, you have to think, is this my thought or is this an echo chamber? So when did I decide that? Is it true? Is it absolutely true? How would I feel or who would I be if that were true? And suppose the opposite is true. How would I feel or who would I be? And remember the ants. The ants are our automatic negative thoughts. Our automatic negative thoughts are those little processes that can affect us because of our lived experience. And we also have to be careful, especially as health professionals, of hunger, anger, loneliness, and tiredness. Because when we are hungry, angry, lonely, or tired, we are not our best selves. So we have to make sure that we take our food with us to work, that we take our fluid with us to work, and that we learn how to control our emotions, and that we get our rest. We need to get really adequate rest because it is in rest that we're healing. The serenity prayer, let us all pray this now. God, grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. Our Almighty is the first one I call and hold on to. He can sort any and everything out, and he can actually link me to any and everyone else so that whatever I'm in, it can sort out. And he will do that for you as well. So think on things that are lovely and of good report, things that are true, helpful, inspiring, necessary, and kind. And you want to have boundaries to keep you safe. Now, yesterday, we had a speaker, Robin, who spoke about deep sea mining. We have the conscious mind that you know quite a bit about and the unconscious mind. And trust me, the unconscious mind is deep sea mining. If you do not know about it and you're watching social media, things are leaking down and affecting your programming. So be careful. So our lived experience, we've all lived through life and we respond to stress. Stress is an overload of the body and overload of the mind. Look at the green area. If we can remain socially engaged, like the pets, going to the park, just talking with our neighbors, just feeling the sense of joy, being present, being grounded, being curious and open, feeling compassion, being mindful. This will all connect us to safety. It will orient us and keep us safe. No matter what the stress is, we seem to be able to handle it. However, there are times when the load gets really more, and we may feel emotions of rage, anger, irritation, and frustration. And this is what you call movement toward. You're fighting, and when people are fighting, they go toward things, right? This happens a lot in Jamaica and around the world, because we see all of these wars. And then flight, we see panic, fear, anxiety, worry, and concern. And these are away, movement away. And we see a lot of these in our practices. Above this pink zone, there is the freeze zone. In the freeze zone, the person actually, the energy just drops. You know, sometimes you will feel it. I went through something like this actually last year. A friend of mine had passed on. It was just like a bombshell. And the whole thing, and it's just like I couldn't do certain things regarding something or another. I won't say. I just couldn't do certain things to process certain information in a box of charts that I had. Until I said, you know what? I know what I'm going through. I had been processing the stuff, but what I needed to do was to take action. And what I had to do was to bring my friend who had passed on, pretend like I'm in Carib cinema. You saw all of you pretend like you're in Carib cinema, okay? I brought her on the stage, and I'm going to call her Miss B. I said, Miss B, I know you passed on, you know, and you're a really, really good friend of mine. You've been a good friend of mine since I was age 16, and I really, really miss you. I want to tell you, Miss P, that I love you. And then she responded, it's all playing out as a story in my mind. She tells me in response, you know, I love you, Aldo. And then I said to her, you know, Miss P, if I've done anything to you at all that may have hurt you in the past or whatever, please forgive me. And she responded similarly, you know, Alice, me too. Anything at all, please forgive me too. And I said, you know, Miss P, you wish my highest good. You wish that I thrive, just like I want you to thrive and be happy. She said, oh yes, I want you really, really to do well and to be happy. I said, well, guess what I need to do? I need to cut the cord that links you to me. So I literally used my scissors fingers and snapped the cord. And I said, I release you to your highest good. You have a wonderful adventure. Go. So I had to release her from me energetically. And I literally did it in the presence of this box that I was to work on. And as I did it, because that was action, I went to the box and took out every single thing out of the box. And trust me, in 2 2s, like within 2 days, I finished everything that I was supposed to do in that box. That took me roughly many months. I hadn't touched the box for many months. Now that was a freeze experience. Because here it was, I was trying to conserve my energy. I was going through depression, numbness. I was dissociating myself between myself and the box. You know, I was feeling a bit shut down. But I realized what was happening. Because it was just like a part of me doing this, but I still socially engaged, turning up, you know, and seeing my patients and so on. So sometimes it can happen to a part of you and you can move on, but you know that there is something happening. So the technique I showed you a while ago with the cinema thing, it is actually called Ho'oponopono. 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 It's a Hawaiian healing technique where they say that you forgive twice. you forgive twice, whatever is. So I say something, the person says it back, and then you release the person. Now you can call the person back anytime, you know, but you need to be able to release. It's so important to love, forgive, and release. And those are the elements that I did in Ho'oponopono. All right. So we need to be a cause for your solution. So you see in this, in my experience, I had to be a cause in order to move up. So how was I going to show up during this time? You know, because there is this fear zone, the learning zone, the growth zone. Trust me, I learned and I grew. And so it's very important to have a very important, you need to be in a resourceful state. You know, that resourceful state, think of, what is his name now? Usain Bolt. When Usain Bolt is going on and he goes on the tarmac and he's there putting his hands up in the air and clapping, that is what you call a winner's stance. So everybody right now, wherever you are, I'm going to stand up and I'm going to put my hands in the air and clap, okay? When you do that, you notice the difference you feel from when you're sitting down to when you actually stand up. The energy field has changed. The energy field has literally changed. And I hope that you did the experiment. You literally get up and you feel the energy change just by changing the location of your butt, just by changing the location of what is happening with your feet. Our system has a nervous system. We have a nervous system, and the nervous system connects. Our nervous system connects our internal world, our internal realm, to the outside world. Our nervous system can change our mood just like that. It can go from good to not so good, and not so good to good. Your state can change really, really fast. Now, if you are at the effect of others, that means like people are using you as a doormat. That's no way to live. And guess what? If that is what is happening to you, then we're going to continue this because maybe you're having a program that you want to change up a bit. So we want to do the life balance audit. Check. Do you have anybody, any members of your family and friends that you can rely on for emotional and material support? That's very important. Do you have a sense of control? The sense of control would be like techniques you need to learn, okay? It could be breathing. You will have certain things in your toolbox already. I am comfortable with unpredictability. I'm usually optimistic that bad situations will always improve. I believe my life has purpose and meaning, and I can participate regularly. But it could be like walking, singing, meeting up with a friend, you know, just even being up with an elderly person, just being present, praying, just being present with the Lord. Life balance audit is very important. And you got to have the balance. Set your limits, manage your time, automate, delegate, and eliminate. Make a list, my friends, prioritize. Learn to say no. That is such a wonderful word, no. Leave work at work, reduce your email access, take advantage of your options, and try to shorten commitments and minimize interruptions. There are steps in program planning. Basically, you got to know the reason why you want to make a lifestyle change, identify your needs, set realistic and achievable goals, select whichever lifestyles you want to work on, whether it's sleep, exercise, mind, working on your mind, emotion, nutrition, relationship, whatever it is. Maybe you need to learn how to make good rapport, group environment, gardening, add hobbies. There was a time in my life when I felt like I needed more. I really, really needed more than the skill sets that I had. So I decided that I was going to get trained in neuro-linguistic programming, in hypnosis, in time techniques, in emotional freedom techniques, and in coaching. I decided because I wanted something different. I wanted to help me and I wanted to help my patients. And why I did it, because one day, one of my training programs in smoking, I was in Mexico, and one of the psychologists said, doctors don't know how to talk to patients. And I said, say what? Doctors don't know how to talk to patients. And I declared that I was not going to get a doctor to teach me this. I needed to learn how to communicate differently, so I can help myself, my patients, and share whatever I learn with you. You got to prepare a written plan and keep records of your progress. So basically, you got to know what your outcome is and work it backwards. Work it backwards so that you can achieve the outcome. Very important also that you quarantine your interferences. You got to know your internal resources, that's the internal strengths, and the external resources. And you are not going to focus on your problems. You're looking at your solutions. You see yourself as Wonder Man or Wonder Woman, right? You see that golden person right there and you're going to reach for it. So suppose we learn about sleep. So some of us have patterns that don't really go with good sleep hygiene. So if you want good sleep hygiene, this would be the program for it. You want to stick to one sleep schedule. Starting at about 2 p.m., you eliminate all the caffeine. 3 hours before bedtime, you stop alcohol. 4 hours before bedtime, you stop the exercise. And give the sun a high five every morning for about 15 minutes and do early morning exercise, because this would reset your biological clock. So this would be a program that would work if you don't have a program that's working for you. Because when you do this, you're going to feel like a great person. Now, self-havening techniques. Now, remember the thing about the trauma. Let me get back up here. Let me go back up here. Yes, this thing that we all face is stress. When we face stress, what happens is that we have certain waves that really vibrate very fast, and they're called gamma waves. They're going between 100 to 200 cycles per second. They're really fast frequency, but these waves are the ones associated with trauma. These are the waves that will hardwire and encode trauma in a place in the brain called the amygdala. It will hardwire it within seconds. And when it hardwires it, if a familiar situation comes, the brain will say, we see this already. Remember I said familiar or unfamiliar is going to sort. And if it sees something that resembles something that is stored in the amygdala, trigger. You're going to either have flight, fight, or freeze. So that is the gamma waves. That is the frequency associated with the flipping stress. Now, when you do the havening techniques, now I want all of you now to cross your arms like you're hugging yourself and put your hands on your shoulder, at the shoulder, and gently stroke your arms down. As you get to your elbow, lift them up and go right back to your shoulder top and stroke downwards. And the pressure that you put on your arms is the same pressure that you'd put when you're petting a dog or petting a cat. And this is why the animal therapy is going to work. It's through touch. It's through touch. Because when we keep stroking, I hope you're doing it, because you're going to notice something. Put your hands on your top of your shoulder and gently stroke yourself, because you're so special. You can think if you're a pet, if you want, you're your own pet, right? You're your own pet. You deserve to be loved. But what this does, generates delta waves, which are ultra slow waves, about 9 cycles per second. What a difference between 100 to 200 created by the traumatic gamma waves. 9 cycles per second by the delta waves. And the delta waves are the ones associated with what? Deep sleep. That's why I told you the program, how to program for your sleep. Because you are, especially if you never got much sleep last night, you can start doing the shoulder, going down to the elbow, doing that, all right? So as health professionals, bring up in your mind, just replay it, things that happened today. Something upsetting, something happened at the hospital or a patient or whatever, even families, and just start doing this. And you just see the mind movie going on in your head. And breathe as you do this, stroking your arms gently. You're not doing it fast, just gently. And then you should notice after a while, if you continue doing this, not if, you should notice that when you continue doing this, that the sensation, the emotion connected to the stress of the day, it just goes. Just doing the self-havening technique. So it's something that you can do, all right? But what it does, how it works is because the traumatic emotion that is embedded in the AMPA receptors of the amygdala, they get depotentiated when you actually touch yourself. They get also depotentiated when you stroke an animal. So that's the pet effect. And you're your own pet, right? So there is science behind it, and it's written up in the National Institutes of Health. Many journals have it in. So be still and know. Stop. You're really busy. Connect to Almighty power. We won't be around if there is no Almighty power. Thank God for Almighty power. And my friends, consider how you can spur one another on to love and good deeds. Remember I said programming? See how you can plant peace in your life. So you want peace of mind, peace of heart, and peace of soul. But you can only get that if you are still. Not if you're busy. You got to be still. You got to find time to be still. Because when you're still, you will find God. Plant rows of peace, peace of mind, peace of heart, and peace of soul. Squash the gossip, squash indifference, squash grumbling, squash selfishness. There's a program for all of that, you know. So if you find you're doing this, then you need a different type of program. Then you have lettuce. Lettuce is really let us. Let us be faithful. Let us be kind. Let us be patient. Let us really love one another. There's a program for that too. And turnip. We need to turn up for our meetings, turn up for service, turn up to help one another. There's a program for that too. It's really an attitude, right? And to conclude, our garden, we must have time. We need to have time for each other, time for family, and time for friends. Time for God, time for prayer and meditation. Water freely with patience and cultivate with love, because much fruit in your garden will be there because you reap what you sow. Now, there's another program. It's called the Add Heart program. And it is so, so special. So I showed you the havening technique, right? Now, the Add Heart program, just remember what your heart represents. It's an organ pump. It's pumping the blood through the body. However, it's an information processing center which sends important information to the brain and the rest of the body. It's not just a pump. It sends information. Many of the highest quality emotions we experience, such as appreciation, care, love, kindness, patience, and compassion, are born from the heart. You know, the scripture says, love the Lord thy God with all your heart. You think the heart doesn't have some connection? It has connections. The Lord likes appreciation, care, love, kindness, and patience and compassion, right? They are born, they are qualities of the heart. It is associated with deeper wisdom and intuitive knowingness that bypasses normal, logical, linear thought patterns. It is not a cognitive, it's in the unconscious. Let me put it like that. So the heart lock technique. So this is so if you go to heart, H-E-A-R-T, capital H, common E-A-R-T, capital M-A-T-H.org, heartmath.org, you will find these techniques. So the step one is just breathe. Just breathe. Focus your attention on the area of the heart. You're going to have something special, you know, so do the exercise, all right? Just be curious enough. Focus your attention to the area of the heart. If you want, you can put your hand on the heart, all right? And then imagine, so your hand is on your heart and you're focusing your attention on the heart. Now imagine your breath is, you're breathing into your heart. So imagine your breath is flowing in and out of your heart or chest area. Breathing a little slower and deeper than usual. Just breathe in and out of your heart area. I pause because I'm doing it. I'm feeling really good about this, right? Just doing this. And trust me, you can do it to your dog and cat too. and put it on their heart. So the heart focused breathing can be used as you wake up in the morning. Just be still. It can be used, the heart focused breathing can be used to create balance, calm, and harmony. Just putting your hand on the heart and breathing into the area. It can be used to reduce feelings of anger, irritation, and frustration. I remember I was talking with a colleague and I couldn't get what he was saying, but I know he had his own perspective. You know what I had to do? Because we're talking on the cell phone and I was feeling a bit irritated. I put my hand at my heart, and I started to breathe. And I felt the shift. I said, you know, I like this person. He has his own perspective, and so do I. But when I listened to him more and more, I understood. And I said, you know, thanks for sharing. I understand where you're coming from. But it helped because I was able to get the delta waves. It's the same delta waves too. Reduce the feelings of anger, irritation, and frustration. Put your hand on your heart. You can use it also before important phone calls, just putting your hand on your heart, or other types of communication. And you can use it right before going to sleep. This is a heart lock-in technique. Put your hand on your heart and breathe into it. So many useful uses just breathing into your heart. All right. So I told you that the heart is not just a pump. There's a neurological part to it, biophysical, hormonal or biochemical, and energetic. Do you know that there is an electromagnetic field that surrounds us? The heart creates this 360 degrees radiating from our body about 3 feet. Our emotions are imprinted in this field. And this is an unseen level of communication taking place all the time through people's energetic field. So somebody comes into our space, they may be within our 3 feet space, and it's like you can feel them. So it's called heart coherence. It's a highly ordered physiological state that can be generated by positive emotions. When you are more coherent, the power to add heart qualities increases. So coherent heart rhythms also activate more of the higher brain centers, giving the ability to perceive differently. The power you have to add heart qualities increases when you are more coherent. So that's why I said, put your hand on your heart and breathe into it. You just notice it's almost like a perfect sine wave. It's not jagged like some wicked arrhythmia or fibrillation, right? Just to bring up a visual for you, it is just a nice sine wave. The heart coherence can be measured by analyzing heart rhythms, the heart rate variability analysis. So they've done science on this. So put your hand back on your heart, breathe into your heart, breathe into your heart area. Now think of somebody that you love, or a pet you love, or something. Just choose something that you love. Okay, I'm thinking of somebody that I love, and I'm putting the person right into my heart area. And as I look at the person in my heart area through my mind's eye, I feel appreciation, I feel care, and I have compassion. Right? All three, these three, you can feel love in this, all right? But just this regenerative feeling, it's just breathe in and put something or someone that you love right in the heart area. And breathe in. And when you breathe in, it's like the person is glowing and growing. You can even put a warm feeling into the heart area. So to do this, so what I'm doing with you is like a little bit of hypnosis, right? But it's also hypnosis. Just follow what I asked you to do. Just remember how the sun feels when you're in the sun and your forearm gets really warm. You feel that? And then transfer that warmth to the heart area. So you have the person you love in there, and you have the warmth and the glow. And you're breathing into it. This wonderful regenerative feeling. You appreciate the person. The person has cared for you, and you've cared for the person. The person has had compassion for you, and you have compassion on the person. And reflect on this experience. Now, what Joe is talking about, no, not yet. So remember that these heart rhythm patterns, I said sometimes the jaggy thing is when we are feeling angry, we're just too busy. This is how we are. It's not a good pattern for the heart. But when we have the heart rate variability coherence, and it's like a nice sine wave, we feel so much in balance and in control. So the coherent heart rhythms can really be increased by feelings of regenerative emotions. That's why we want to think about wonderful things. So take away, when you're doing social media, just be careful what you look at, because it won't affect your heart. Coherent heart rhythms help synchronize activity in the brain, which is critical for optimal mental functions, such as memory, focus, and decision-making. When we learn how to shift into a more coherent state, we feel better. Now, they do have, HeartMath has a inner balance trainer, which is a tech tool that you can use to practice getting the nice sine waves. Now, Joey had mentioned about the feel-good effect with the dog. Now, here it is. HeartMath had done Holter monitors on a boy and a dog. Each of them had their own Holter monitor. So you see the jaggy thing first in the thing? This is the dog's name is Mabel. So Josh and Mabel are in separate rooms. And you see both of them feel jaggy. But when they come into the same room and see each other, now they're not connected, no petting or whatever, just the sight. Josh loves Mabel and Mabel loves Josh. And look at the synchronicity there. You see that pattern? Yes. That's what it is. Heart coherence variability is improved when you have a wonderful regenerative feeling in your heart area. So, I think I did this part with you. So I had asked you, put your heart on your heart area, put your hand on your heart area, breathe, put some on your love there, and then you put the emotion of love, care, compassion, appreciation right there. And then you put the warmth from, you put the warmth and the glow there. And just feel that right there. Just imagine that is there. You have your hand on the heart area. And just imagine that there is somebody that is not really pleasing to you. Or, you don't really take much tea with them. But you close your eyes. The person is, going on and on and on. Put your heart on the heart area. Could even be a word round. It's going on. Put your hand on the heart area, because you're going to get in a really resourceful state. Remember, you're captain of your ship, right? Put your heart on the heart area. However, and then when I have your heart on your heart area, and that glowing, warm feeling, the person that you love is right there. And then you look toward the person that you really don't take tea with. But you know what happens? You're looking at the person with warm regard. And the person is going to feel the shift and say, "Is what happened here?" Because you have changed into a more resourceful state. And you can do that anytime. If you're exhausted, or if there is someone you don't really take tea with, you can just do that. It's very important that we do this, right? So the other thing is that I want you to share this information with your patients, because they're going to get better really quick, right? It's going to build rapport. So when the patient is coming in and you just breathe in the heart area and you look at them with warm regard, you get the immediate rapport just by how you're looking at them, right? You're connecting better, and they're cooperating. You're cooperating with them, and they're cooperating with you, because you're actually the waves have synchronized. And the other thing I'd like you to do, speak your patient's language. Yeah, I know you speak English. However, the person processes information differently. So listen to how they structure their thing. May I say doc, da. So I would say, may I say Miss Lily, da. They get it, because that's how they're processing their info, right? So you can use chunks of how they talk as well. all right? So because you want to communicate. And so you can keep it simple and casual. You don't worry if you're getting it right. You're getting it right because you are generating the warm regard. You can break the ice, you create the rapport. And guess what? You're the best dog ever, right? You're the best son, your best daughter, you're the best parent ever because you even carry it into your family. You're the best pet owner ever. And you find that even if you have a quarrel with a family member, you can discharge the emotion just by putting your hand on the heart area, breathing into it, and looking at the person with warm regard. You say, you know what, that's it, right? Take your pills. Positive resourceful state. Remember I said Usain Bolt? Physiology of excellence, psychology of excellence. You get information from credible sources. Have your lifestyle changes. Now that is, you want to program that, you must be willing to adapt. Love yourself and love others. Use the heart technique. Warm regard. And you know, when I go to certain communities, I hear manners and respect. So it's always manners and respect for ourselves and other people. And we must be willing to give support and we must be willing to receive support. I find that sometimes we are willing to give, but we're not willing to receive. Actually, being willing to receive is a gift you can give to another person. It's okay to receive because you see the smile on the face of the other person. I'll give you a joke. This is really true. So mommy had her pastor come in and we have this pet Labrador. Her name is Coco. So Coco usually likes these Christmas, you know, the Christmas berries. So she came in to mommy's room and the pastor is there talking and he's sitting and she put 3 berries at his feet. So I looked at it with interest and I said, Pastor, the dog has brought an offering. And he said, Bailey, but he hadn't really paid attention to what I was saying. So Coco said, and took up one. She took up one and left 2 berries at his feet. I said, Pastor, you don't see the dog come to church. The dog is concerned that you have not taken up the offering. So he took up the offering and made much of Coco, and Coco was well pleased. The dogs have a lot of sense. There is Doc Children is she works very closely with heartmap.org, and I'm going to quote what she says. And I encourage you to go on heartmap.org. They do have a special this month where you can actually access the program. I'm telling you, free for the month. So you can go on it and look at it. She said, love, compassion, kindness, and cooperation have been sparsely represented in our collective social consciousness for too long. Let's place these transformative heart qualities on the top shelf of our toolbox as we pitch in to co-create the highest, best future for the whole. I feel that being kinder and more compassionate to each other is the best kept secret for quickening the advancement of humanity. As we do this, the rest of what we need will follow. Accessing our natural heart intelligence can create an energetic field of unconditional love and harmonious interaction, helping humanity to realize we are one earth, we are one yard, we are one people. Love is the one thing that can bring all this together coherently and eventually thrive. So our response to stress, our response to overload of the body and overload of the mind, we have discussed some tools. Remain socially engaged, please. If you're feeling any of the stress responses, you can thwart the gamma waves by using the delta waves. Start doing the havening, self-havening, and you can also get in touch with your heart's energetic field. Add heart to everything you do. And remember to take your pills. P, positive, be in a positive, resourceful state. This is the physiology of excellence. Remember you saying? And the psychology of excellence. Get information from credible sources. Look at your lifestyle, what you need to change, work on them one at a time. Sometimes you just need to tweak something for it to click. And then you can always reassess. Love yourself and love others with warm regard. Be willing to give support and be willing to receive support. And my friends, just as we're leaving, the formulas for success. Know your outcome. Know what you want. You want to take real action. Remember what I tell you when I was in the freeze response? I had to process. I had to bring my friend on the stage. I had to tell her that I love her, I forgive her, and I release her. And she had to tell me that too. I love you, I forgive you, I release you. I had to cut the strings so I was released energetically from her. And then what the real action now was to get into the box. That I wasn't able, it's like I couldn't touch it. And it was a simple thing to touch it. But it was like there was some energy block. And when I cut it, trust me, I did it right in the presence of the box. And I took everything out of the box. And within 2 days, everything was done that was supposed to be done in the box. When the Bible says, ask, seek, and knock. Ask, and it shall be given unto you. Seek, and ye shall find. Knock, and the door will be open to you. These are action things. Pay attention to your results. So you know your outcome. Remember, I tell you, you need to work it backwards, right? So that you know the steps that you need to take to get to your outcome. Pay attention to your results if you need to tweak something in your program. And be willing to change. Focus on excellence. And above all, live with gratitude and integrity. Create the patterns that work for you for coping for success. And I want to show you, let me come out of this and I'll show you something. I'm going to take this off and get back. Stop share. Stop share. I want to stop share. All right, that's okay. Everybody put up your hand. I'm leaving with this. Put up your hand. What is this? Right. This is positive resourceful state. Thumbs up. I choose to have a thumbs up day. I choose it. Right? I choose this. And I can get in a more resourceful state if I put my hand in my heart. Even into my heart. Put whoever I love in my heart. Put the warm feeling from the sun into my heart. And it's glowing. And then I can look at you with warm regard. I love all of you. The thumbs up day. Choose to have a thumbs up moment. All right. Sometimes we have to go moment by moment. This is the pointer finger. Point in the direction you want to go. You know your outcome. Point in the direction. Flick away fear. If you feel afraid, you can literally flick this, and keep flicking it. You're going to just notice. It's almost like a dial. This touch. Hey, what happened to that feeling? It's gone. Just flick away fear. This one here is the fourth finger. Go forth. Go forth. Go forth means take action. And this little one is give thanks. Always. So let's do it together. Thumbs up. Pointer finger. Point in the direction you want to go. Flick up. Flick away fear. And if you keep flicking, you just know the anxiety goes right down. Go forth. Take action. What is life without action? Even if you're in the presence of God, that's action. Because you want to be still. Being still is action. And give thanks. One more time. So repetition is the mother of success. Thumbs up, Dave. Pointer finger. Point in the direction you want to go. Flick. And you can keep flicking away fear. Suppose something is happening. You can just keep doing this even under the table, just flick it. You can breathe into your heart area, or you can do your haven things. So many tools you have today. Go forth and give thanks. And when you're talking with people with warm regard, you're listening and you're using some of their language so that you're making really better communication. Because God bless you all. Mayday, how we can cope with stress as health professionals. Thank you very much. Over to you.
Thank you, Dr. Buckland. As always, I'm always so relaxed after your presentation because I do it. I sit and I put my hand over my heart and I start to breathe.
I feel you.
and it's just so good.
I feel you.
know,
Thank you.
Thank you so much. And then
It's
I
okay.
thought what was super cool was the graph you showed of the little boy and his dog and how their hearts just aligned. You know, just that love is so cool. It was just amazing. So thank
There's
you.
a sense behind it. It's all written up, you know.
Thank
So
you
I just
so much.
asked Joey to look at what I have there and put the science behind it. It's right there. So I know he's doing the observation, but the science is right there. God bless Joey and the wonderful work, you know, that is happening in Jamaica. Thank you so much.
Thank you. So I'm going to check the Q&A for any questions. I see one. Is the box breathing technique effective in reducing anxiety?
Of course, that is another tool. That is another tool. That's breathing. However, you can add on, because, all right, let me see. The amount of delta waves on the receptors of the skin vary. So let's say this one is, I think the face is the most. So this is like 100 times. So I showed you only this for havening, but you could also do this. You know, you feel good when you do a massage on the face. I can do this. I can even do the scalp massage, but this is 100 times. This one is like, I think this is 30 times. The hand, if you do the hand, is like about 9 times. So the face is actually very effective. You know, it's just like sometimes you just do this. And laughter is also the best medicine. So, yeah, box breathing and add on. Guess what, guys? Tools in your toolbox and just add on anything you want to do.
Love it. Thank you so much. I see people laughing. I see laughing emojis and a lot of comments in the chat. Excellent presentation. Great presentation. I'm going to take my pills. Somebody says, this is very relaxing. Thank you. Very positive, very practical, very relaxing. God bless you and keep you and strengthen you so you can continue to strengthen others. Hallelujah. Bless you, woman of God. Thumbs up day, therapeutic. So many wonderful comments. Lovely presentation, thought-provoking and applicable. I felt that motherly love. Just fantastic, everybody. Thank you.
You know, I want to say one more thing. I read a study, it's about a high school in Naperville Central High. It's a trouble school. And the PE coach, he had a bright idea because, you know, it's like they were reducing PE staff. So he asked the teachers if he could have the trouble students come and do 12 minutes of exercise before their hard classes, the ones that they get really bad grades in. And you know what happened? Those students, after they did 12 minutes of exercise with him and went to their class, these people, the behavior was excellent. They could go on the blackboard, and even if they didn't know the thing, they were willing to participate and do something with the teacher on the board. They got straight A's. That school actually came #1 in the world. And people from Finland, Japan, different places came to Naperville Central to find out what was happening different. And I think our Minister of Education need to look at what happened at Naperville Central, because the kids in Jamaica are stressed. They are stressed. They have long hours of homework, long hours of projects that they don't even know how to sort out. And sometimes the parents don't know how to sort out. They need to rethink how education is done. But the kids need to have activity and they need to have fun. They need to have playtime even just before, or the teachers do it before they do the class. They could do a dance thing. Just get their kids moving for a few minutes. They're going to notice something different because the kids will be in a more physiological state, just like Usain. Remember what happened to Usain? Usain's teacher recognized that this kid needed to go outside and play. If she had brought him up in the classroom, he would not be where he is today.
Yeah.
So I implore all the educators, please, de-stress the children and allow them to do some movement in the class so that they will settle down. and they will have a wonderful time in the classroom. So because what is happening, we will have children or grandchildren, and it's coming to affect us as health professionals, or we have other people's children or whatever. But if they would have some, when we were little children, we got time to play. These children have no time to play. It is one thing after that, and after school another something, and before school, extra lessons, and after school, extra lessons. There's no breathing space.
Yeah, yeah.
You know?
And I'm a mom that just had a child that did PEP, so I can totally
teach your children
understand.
Teach your children how to do the havening.
Yes, yes.
Teach your children how to do the heart thing. It will help them. Havening, and it will help the kids. Thank you so much.
Thank you, Dr. Buckland. Thank you. All right. And I don't see any more questions in the chat. And I second that initiative. If anybody has the air of Minister Tufton and Minister Williams, please let us see if we can push. You know, we talked a little bit about today that political will has to be behind some of these health changes that we are hoping to see in our world. So at the end of the day, we have to see how we can get the politicians, unfortunately, involved and feeling like they have a responsibility for the health of our children. So if anybody, I mean, maybe we can think about that, Dr. Cadogan, you know, we'll see. But in the end, we have come to the end of a fantastic 2 days. I mean, can I get some hearts, some heart emojis going up, because I know that this has been, see them there. I know that this has been an amazing, amazing, amazing One Health conference. It has been that way every year. And I just want to ask Dr. Paul Cadogan, I want to say thanks, but I won't do it because that is the job of Dr. Paul Cadogan. His job is to give the vote of thanks. And I just thank you for having me here, and have a wonderful, wonderful thumbs up night and thumbs up days tomorrow and for the rest of the week. Bye-bye.
Oh, thank you, Kathy. You have done a wonderful job today. You're a great, great moderator. Let's see the emojis going up for Kathy, our moderator. I can't believe that we have come to the end of this conference. I mean, another one under the belt for all of us, and it has been an amazing 2 days, and I am so gratified at the attendance, the number of people who registered. I mean, I'm thanking the participants first, because you all made this the success that it has been, and we hope that that you will take, as I said earlier, you will take what you have learned back with you to your work, to your lives, right? In bringing One Health to, you know, to the nation, to the world. And so thanking the Almighty too for, you know, smiling on us and making today work very smoothly. We didn't have any real hiccups as such. So thank you very much. So to be extremely grateful for our speakers today, Dr. Tex Kisson for that sepsis presentation. I mean, we were honored by his presence. Dr. Teola Noel, thank you so much for that leptospirosis presentation, and, you know, showing, you know, what that it is a One Health issue that we really need to take action on in the region. Dr. Tracy Evans Gilbert, that was a fantastic presentation on Angios rhamnosus cantonensis, and opened the eyes of many people who did not know that it's not just lepto we have to worry about when it comes to rats, right? And I have to thank Professor Lindo for volunteering you. He told me that you were going to do it, and when I called you, you said, huh? But we're very grateful that you came on board. And Adana, my friend and colleague, Adana Mahes Gibson, all the way from Canada, it was an absolute eye-opener, and you were brilliant in your presentation. Thank you so much. Joey Brown, thank you so much for bringing animal-assisted therapy, you know, to us all, for that great presentation. I know people, many people were blown away by what animals can accomplish in helping us to heal, right? And all this, my co-chair, my friend, phenomenal. Once again, she has closed every conference over the past few years with this kind of presentation, and the audience has just lapped it up and loved it, and we can take it forward with us. I know I am extremely stressed sometimes, and sometimes I sit down in my office and I've done that technique to try and calm myself down. So thank you for all these wonderful presentations. And for yesterday as well, just to recap, Dr. Paula Henry giving us the introduction, Dr. Sandeep Maharaj, Dr. Jennifer Pradell and Lorelei Corso, Robin Young, Dr. Eric Garraway, Dr. Shane Ramsubik, Dr. Anna J. Brown Morgan, Dr. Audrey McNabb. All of you really made this conference special and have brought a whole lot to the table. So thank you all. Thank you for taking the time to prepare and share, as I said yesterday, and all of you, such talented, dedicated, and brilliant professionals. To our sponsors today, Hypro, Humanima, Nutramix, Grace Kennedy, and Healing with Horses. Thank you so much for your support in making this conference possible, making us able to cover the costs of all of this. So thank you so much. And for yesterday, GlaxoSmithKline for sponsoring the day and having their presenter, Dr. Paul Scott. We are grateful for him too. Thank you to our moderator today. As I said before, Dr. Kathy Ann Leon, she was extraordinary. And also yesterday, Dr. Jackie, who had her internet problems, but still she came through like a trooper, Dr. Jackie Campbell. And Sam, you are phenomenal. You have shepherded, fixed everything. Yeah, you had a little certificate snafu, but we know say you have been doing so much. You're tired. You get a ease. All right, so don't worry yourself at all. Everything is good. And thanks to the organizing team, Ccfpj-Jvma, Haldith, Arna, Seni, Lynn, Farah, Sidani, Bridget, Jackson, Sarah, Lydia, Robin, Julie, Kathy Ann, everybody worked together, everybody pitched in, gave opinions, etc., and helped get everything done. So with that, I bid you all good night. Until next year, we will see what we can do to bring you another One Health conference that you will remember and take with you. And we continue to grow. One Health is not a concept anymore. It is a phenomenon. It is a paradigm. It is a way of life. Let us live it. Let us fill that prescription for the health of our planet and keep us going as a species and a world for as long as we can. All right, so thanks a lot. Good night.
Our home, a living, breathing planet, but we know things aren't always right. Climate change, disease emergence, overuse of our resources. We must change our ways and look to better days, but we need an answer to heal our ailing world. Yes, we need an answer. Man, woman, boy, and girl, we need to change, but we need an answer. Health of all is so important. interdependent. We'll rise or fall on choices that we make. Physicians, vets, and virocides too can't isolate the things we do. We must understand health rests in all our hands. One Health is the answer. We can do it if we try. One Health is the answer. Together you and I can heal the world. One Health is the answer. Again, when we come together and understand, united we prevail. For people, animals, and plants too, the land, the air, the water blue. Let this be our song, resounding on and on. One Health is the answer. We can do it if we try. One Health is the answer. And together you and I can heal the world. One Health is the answer. Yes, One Health is the answer. We can do it if we try. One Health is the answer. And together you and I can heal our world. One Health is the answer. It really is the answer.
Good night, everyone. Good night. Dr. Cadogan, congrats to you and the team again. Wonderful 2 days. As I said, it's early January, so still put in 2023 where it should be 2024. But certificates will be sent out by Thursday of this week. You should receive them. And of course, we'll ensure that the JVMA and the CCFP have copies. So if you haven't seen it by Thursday, you can reach out to them and they'll have copies that they can just forward to you. All right, everybody. Thank you. See you at the next one.
All right,
Stay
thank you,
safe.
Sam. All right.
Thank you
Night,
so much, Doc.
everybody. Thank you.
Night, night.
Everybody.
Thank you.